So I put here just kind of a break in the action, and he goes, okay, let's go to change our channel to the charges then, our revenue. And the inpatient revenue for the month of June, if you find it, there's $1,858,000. The outpatient revenue is $14,701,000. That is the two numbers that you use to create the outpatient factor, which converts your basic measures to the adjusted measures, adjusted patient days, adjusted admissions, adjusted.
Okay, on that line, you said it's got 1858, but over in the parentheses, it adds 3 zeros, so that's why you said 1,000,008. That isn't on every line, right? So we need to recognize that
That's $1,858,000.
Okay.
Those are all in millions.
That's because the zeros are shown over by your definition.
But the factor, that just kind of tells you what the factor is. So on average, we were at 7.3 times outpatient revenue to inpatient revenue for the year. But as you can see, during the year, we had certain months higher and lower than that, and there will be that depending on the month.
You don't ever expect that factor to be negative.
Now, that would mean that we're not an outpatient hospital.
Okay.
That means all our revenue comes from inpatient. Okay. The next area is very critical for us, and that is our payer mix. And these 5 basic categories are, it could be broken down further, but Medicare is our largest payer, and they provide for the year, for gross charges, 42% of our gross charges. Okay. Medicaid's listed second there because it is a government provided payer or government payer, but that's only 5% of our revenues for the year. Our largest commercial payer is Blue Cross. It's the only one we list separately because of the significance of it. The next one is United, but it's a fraction of Blue Cross. So we lump that into commercial and other, and then self-pay. So self-pay is between, depending on the month, it's between 3 to 5%, 3 to 6% of our gross charges. And that's
so self-pay is non-insured?
Self-pay can be non-insured, or it's your co-pays and the patient's portion of our gross, the obligations that the patient has on their care.
So self-pay is deductible, co-pays,
co-insurance,
and if you don't have insurance and you're paying everything with cash.
all. Maybe break that out separately, but for this analysis, it just kind of gives you a picture. Most costs in Wyoming are into the upper 50 to 60+% of their revenues are Medicare.
So
that's
the payer mix, that's the number of people?
No, it's the payers or the insurers.
Is that the dollars?
It's the gross dollars, where they're coming from. That patient, if that patient's primary insurance carrier is Blue Cross, they'll fall in there. If they're a Medicare patient, of course, they'll go into Medicare. But we have a number of commercial payers, but I didn't list them all here.
So almost half of our patients are Medicare, Medicaid, which is government paid at cost. It's not really cost, but anyway. I think Dan has something in the report. I read another report. But we augment that then because we're not getting everything we need out of Medicare patients. We have to get money out of Blue Cross, Blue Shield, and other commercials. So that we,
a larger portion of our net profits come from. So.
Nice of you to subsidize us old folks.
Huh? All right, so payer mix could really change a month's results. I've seen it, and Ben really helped me understand early on, like, is that payer mix that caused that problem this month? if you look at it here, look at the month of March, when we only had 30. Oh, I'm sorry.
I just, you know, the importance of the fact that you mentioned that we're at 42% Medicare. And you just mentioned that a good portion of the critical access hospitals are 50 to 60%.
In Wyoming and in general.
And the importance of that is our profitability potential goes up, correct?
Yeah.
Okay. I just want to clarify.
Yeah, right, our potential goes down if we have more Medicare and Medicaid patients, right? That's what you're saying, yeah. I just find it interesting.
But that is important. I think it's important to acknowledge that that is a positive thing.
There's
Yeah,
gotta be
it
a
is.
breaking point number, and it must be about 50% go under review, right? It's naturally working out this way, but there's gotta be a number.
Yeah, so the biggest concern right now in the hospital industry is the Medicaid population because of the big beautiful bill, right? Wyoming obviously was not an expansion state, so we're insulated quite a bit from the impacts of that bill. But if you go to a state like California or Oregon, where Medicaid expansion was huge, their Medicaid population and their payer mix, it can be in somewhere between 20 to 40%. And you can imagine the cuts where that business is 20 to 40%, where those patients are now most likely going to go to uninsured, and the collectability, the fallout of a lot of states that expanded Medicaid, they're saying that it is a poly crisis. Now, I've been in the hospital industry long enough that legislation, you know, it's always hard and there's always going to be a crisis. But I can see how many facilities that are in these expansion states are really figuring out, okay, how are we going to reduce expenses? So you're going to see throughout the country, you know, now that it's passed, a lot of the systems and these hospitals are going to be struggling to figure out how to continue to provide services.
Mr. Chair, I've got a question as well.
Yes, yeah.
The Blue Cross, Blue Shield, the commercial other, all of those, there's typically some bad debt or uncollectible amounts that's associated with somebody who's going through paying my portion and working with the insurance. Are there bad debt recording for Medicaid and Medicare?
Yes, there are.
Okay.
And it's not as big, but there are some. The challenge with Medicare bad debt to get the benefit on cost report, it takes a lot of work, a lot of criteria. It has to be met for you to be able to take that. It's a dollar for dollar refund on your cost report if you can prove it's true Medicare bad debt.
The basis of my question is, if I look, like taking June for an example, it was almost, 9% of the total revenues was bad debt. But if it's primarily the non-Medicare, Medicaid, it's perhaps eating up a good portion or perhaps all of the profits that are earned from the non-Medicare, Medicaid. If most of that bad debt is non-Medicare, Medicaid, that's what I was trying to understand.
Yeah, I think Jeff brings up a very valid point is, you know, we could take our bad debt and we could do a payer mix analysis on that bad debt.
Yeah.
You know, and to your point, you know, if it's mostly commercial, then and it most likely is.
Yes, it is.
It's self-pay that's associated with commercial payer.
So is this on gross charges then? The percentage mix is based on gross revenue or net? On gross?
If it was net, it'd be like that.
I'm assuming we work off the assumption that it is negligible. They're part of the 5% payer portion of the government subsidized ones. Like, you know, you're only going to get reimbursed at cost at best, and then the portion that would have been left over should look negligible compared to commercial insurance.
For
Or
example,
okay.
last year in our cost report, we qualified for $74,000 in Medicare bad debt.
For the whole year.
No, it's almost, because it's very difficult to, to qualify, take a debt, you have to have like 50 different measures on that debt to say, okay, we'll give you $1 for $1 back on that.
So are you
Everybody has to
saying, when you do
continue
that
to say-
analysis, you're looking for the government to step in again when you can't collect from?
Yeah, they'll give you, it's like a tax return, I'll give you
Yeah.
a credit,
Yeah.
tax credit for X, Y, Z, you
Yeah.
know, but it's very, it's a small amount, compared to our total bad debt.
So, question then is it better to be looking at the percentages based on net revenue rather than gross?
If it was net revenue,
Because payer mix would change, right?
It would.
totally,
Drastically, or?
Well, and I don't think it'd be, well, no, it would be drastic.
it would drastically.
Yeah, it would be drastic in the sense that, so if we have a collection rate from Blue Cross Blue Shield of, let's say, 80 cents on the dollar, Medicare would be somewhere around 55 cents. So if we were to change this analysis to the net revenue, it would change the payer mix significantly.
Which is more important for us to track and watch, I guess, is my question.
Well, I think just being aware, this is not necessarily to say, all we're trying to do is provide indicators. We can expand this even further. I mean, we can go miles with
Well,
this.
no, I'm
But
not saying to
most-
expand it, I'm just
If you're
saying.
comparing yourself to others, they compare it on a gross.
Yes. So the hospital industry is doing it on a gross, their charges and then.
Yes, each hospital may have a different contract with commercial payer, different rates. And they're not all cost either, So this just gives us a high level, where's
Where our money's going.
gross charges, our gross revenue before the deductions on a contract or the adjustments to Medicare based on the rates that we're currently at with Medicare at the given time.
Okay.
Okay, the next page gets into more measuring the income statement revenue and expenses by several of these high level areas. The first 6 of them relate to revenue, starting with the revenue that we, the net revenue as a percentage of the gross charge. What do we run, right? So for the year, we were at 59.3. That's 59 cents on every gross charge. Based on the payer mix we have, that's what we're able to collect. And then the next one, I said, well, what then, if you divide the net revenue after the contractual and other bad debt adjustments, divide that by your adjusted admissions, that means for every admission, your net revenue for the year was $24,778. And then if you took away the bad debt from that and divided it in by the adjusted admissions, 22,727. Now the difference between those two, it says for every adjusted admission, we're writing up at $1,500. That's bad debt. Do the math there real quick, but that just kind of shows you the difference between just after your contractual deductions and your bad debt, okay? Then there's 3 bad debt measures as a percentage of gross, as a percentage of net revenue, and then as before bad debt, and then as a percentage of the net revenue. So these are all little different ways to look at bad debt. And I think the one we want to focus on generally is, bad debt as a percentage of net revenue before we deduct the bad debt, which is the middle one. So we were at 8.3 this year. We started the year better than that. We've had, it's just, that kind of show you the challenge in the economy or with our patient base to, we're going into this current plan year with about a 7.7% estimate for bad debt. as a percentage of the net before bad debt. Okay? So we can study that out a little bit, but
So when you talk about bad debt, that doesn't include contractual, right?
contractual is by definition a contract, so it really doesn't count that. It's just like, mostly it's 99% patient-based, you can't pay, whether you're uninsured, can't afford my co-pay or co-insurance, and we help them out. That debt does include our charity care as well. If we could separate that out, it's a very small amount compared to total bad debt.
So what's the difference
Charity care?
between bad debt and charity care? I mean.
Charity care is basically, you have to qualify for it.
Okay.
You can't just forget us, that's bad debt. You never answer our phone calls and you just let us ship it to collections because you won't answer the phone. And we try to say, every time we write something up, we want to have a phone conversation, hear the voice of our patients, and if they can't pay, I'm not going to pay. But they could pay it, but they don't qualify we have a very strict qualification for charity care based on the federal poverty guidelines, what percent they are of that, household size, you look at.
So they can apply, they can make application to us
I
and
did
have it written off.
things anywhere from 25, 50, 75, or 100% that they qualify for when they use charity care.
Why do we track it separately?
I was told to.
Money we're not gonna get. Either way.
It's generally a measure of hospitals, like, a lot of hospitals will measure how much are you giving back, to people who are indigent or just cannot afford, they just don't have the benefit support.
Okay.
They generally don't have a nice big, they really can't pay. And these are hardship cases, and actually, it's quite humbling to read each one of those as I read them and prove them. They're helping people.
Yep.
Okay, the next two sections, inpatient and outpatient, IP, that stands for inpatient. So the inpatient charges as a percent, per admission. This is in thousands, this is the gross charge per admission. 37,000 for the year, you can see how it fluctuates. Inpatient net revenue is 14,738,000 for the year. Then net revenue divided by admission. So it says out of the 37,000 we per admission that we generated, we collected 21,998. The recovery on the inpatient revenue. Okay, and this next section shows an outpatient. We show total charges per encounter was $1,600, but look at the net revenue, 93 million. So that's where the revenue is coming from. The net per encounters around in a call is generally between $900 and $1,400 per encounter. That could be a lab, that can be, a surgery. It can be just a client visit for a wellness check. So outpatient goes anywhere from, here to here. It's very wide, expanse of the type of charge. It could be just $100 or a $40 copay when you see the doctor for a prescription, or it could be, I replaced my hip, or whatever. An expensive ride in a helicopter. But overall, the net outpatient net per encounter, we're in the range of what a typical call would be. I'll get the final numbers later. So, okay, there's some measures that show that outpatient, inpatient. Okay, then salaries and wages. There's a couple of lines here. I've got to find a way to get our payroll system to be more closely monitor this. But if I first thought, I look at, as I close the books each month, one measure as to whether our salaries and wages are in line. I just look at it by day. Take the total salaries and wages expense divided by the number of days in the month. And it comes out to be right around $100,000 a day. That's been pretty consistent this year. So our growth in wages has not been as much as it has been in prior years. I'm gonna find the net wages per FTE hour if I can get that, out of Paylocity. I haven't been able to get that yet. The next area is benefits. This is the total amount of benefit expense. That's everything.
Nope.
Oh, that's not
Nope.
sold. Okay. That's the total salaries and wages and all the benefits related to our people. But this is just the benefits piece of it, okay? And how much that is as a percentage of salaries and wages is that 57.2 for the year. Now, you can't not overlook June, which is 170.6% of salaries and wages. We can talk about that when we talk about our finance committee report, right? And then how much do we pay per FTE in benefits? This shows about 37,000 for this year per person, per FTE, not per person, per FTE for all benefits, majority of which is our health. Okay. Supplies is another big area that it's easy to measure, but we've been very consistent, and I think this area we do really well at. But supplies expense runs around $1 million, a little over $1 million a month. As a percentage of patient revenue, it covers, you know, around 12% plus or minus for a 12-month period. You take that divided by the number of by the adjusted admissions. That says somebody walks into the door, we spend $2,000 to $3,000 of supplies on that patient per admission, adjusted admission. And then per patient day, it's about $900 a day per patient, adjusted patient day. Then if you take operating expenses in total, that's that next line there, which runs $8 to $9 million a month per day. You can see this is what our days cash on hand is factored. You know, that's how we compute days cash on hand. Just take total cash divided by this average expenses per day. Expenses as a percentage of patient revenue. You know, it's going to be in the high 90s because our operating margin is generally less than 5%, which is pretty good for a cough. So you'll see that probably be between 95 and 97% for us in general. And then if you look at expenses as a per patient day, $7,000 on average this last year. This is a start to look at some of the operational results based on activity.
Thanks, Scott. Any questions from the board?
Do you think of anything else you'd like to
Hopefully you
see?
understand it all perfectly now.
Okay.
What's that?
On the report, he's asking.
Oh, not that I know of at this point. I'm always looking for efficiency statistics.
Mr. Chair.
Yes, go.
Just one thing that I would mention on there is when you're looking at the, some sort of standard for us to go off, I think the importance of that is it's great to look at how we've been doing and, going forward, we can compare, to our historical numbers. But, again, one of the things you mentioned right off the top is that we're supposed to be, I think it was, can't remember which one it was, but you're like, we're was it adjusted admissions? Or no, it's when you calculate the outpatient equivalent on the adjustments. They're saying we're typically 7 to 9 times. But I guess what I'd like to know too is that where we should be? And so can we look at any of these matrices and say, hey, this is where we should be, this is where we're tracking, and maybe there's some reasons why we would,
Right, exactly. I think I was trying to provide, and I'll have it by next time we meet.
That's going to be your next column, right?
That first column. Dan and I want to spend some time because it's not a cause, right? It just depends on where you're at, you're located, what your inpatient versus outpatient, based on you don't have any specialists, you don't have an operating room, those kind of things. So outpatient includes like a clinic visit all the way to a major surgery or an accident or a big, emergency room. So that's all outpatient.
I guess my thought would be is that if that column is going to be valuable, rather than just input, a nationwide industry standard or statewide, or whatever it is, we need to,
Our standard.
yeah, I mean, we need to take a look and try to say, hey, this is where we should be based on our location, based on our mix, based on, whatever, just so it's relative to our organization. Does that make sense?
Correct me if I'm wrong, but one of the pillars is to look at 2% growth or something. And so basically putting the number from July 2025 and then
Our target.
2% growth.
Yeah, what's our target?
And then he's just saying, where are we tracking on that assumption?
Well,
Is that helpful?
not necessarily, because, I mean, I'm not saying it's not helpful, but that's not necessarily what I was saying. I was saying, like, if we can have our goals, but that doesn't mean it's goals for other organizations that are in a similar boat. I'm just saying, it'd be nice to say, hey, this is where we should be.
Or Star Valley Health?
So let me give you an example, like, a couple of board meetings ago, we talked about bad debt. And we're running right at that 8 to 9% number of net, right? Where we would like to get to is 5 or below 5. So we could, if you want to, we could have kind of industry range, but we could also provide another column saying, hey, this is what we're shooting for.
Well,
This is what we believe we can get to.
And I guess what I'm saying is just being able to back up the number that you're putting in there as this is a reasonable number for Star Valley Health or what we should compare it to.
Totally. Yeah, I think what we'll do is we'll add a second column. And because as operators, we want to improve these indicators. And we want to show that, hey, we're getting more efficient in various areas. And that's really the whole point of measuring something, right? And reporting on it. Right. We don't want just, hey, look at all these numbers, guys. This gives the entire organization an operational baseline to say, what do we need to do to improve this? What are the action plans?
Right, because to your point, a nationwide average or industry average may be this, but it's not really pertinent to Star Valley Health because of this. And so just so that we can back up where we should really be at, and so we can actually compare, hey, it just makes it more clear.
So one comparison is gonna be our peers, and the other comparison is to what we want to get to.
Well,
What's-
because I'm gonna reduce our plan for fiscal 26 to all these measures. So that we'll see as we roll through the year, how close we're tracking to that plan, to getting to that point, based on the last 12 months.
Any last questions?
Thank you.
Appreciate it, Scott. Thanks for the education. Eileen Merritt, see you're in the public here. You're up next
She told me.
for some public input.
I thought it was after her. I'm Eileen Merritt.
Yeah, tell us where you're
Tell
from,
us who you're.
a little background.
Yeah, you don't know who I am.
I do, but not everybody does.
You know where? I'm too short.
Does that go down? Yeah.
There we go.
We could get a stand for you.
Can I have steps too? Yeah, that's it. I just want to thank you for giving me the opportunity to come and talk. Chairman Sherman, that's the last name, Ordina,
Ordina, yes.
and board members. I'm happy to be here today. Last month, I've been helping an elderly person dealing with attorneys and a judge, and he gave me some really good advice. And the lesson he gave me was facts. So the information I'm going to give you is firsthand. I've been doing what you asked me to do, Mr. Sherman. I'm Eileen Merritt. I run and operate Legacy Homes Assisted Living. I was on the school board. I work for 2 home health agencies and in the elderly population. That's kind of what I do, is take care of old people. So, but recently I was in your ER and I was impressed. They did an excellent job. And I was surprised the gentleman, the doctor that was in there was from Casper. And come to talking with him, I found out that he was board certified. And my question as a patient and a community person was, why are we having board certified? We have to have board certified people in our ER. Is that a requirement? Because like when I was an EMT, I was licensed in the state of Wyoming, but then it came so that you could be nationally. So is that something that we are paying for, to be a board certified ER? Because personally, as a patient and person of this community, I would rather have someone with the experience that Dr. Card or Dr. Stiver, Dr. Perks had, than a piece of paper that says he's board certified. And what is that cost of that? So I was then having symptoms. I went home and I had symptoms again and ended up calling the ER. And I was told that the ER doc would not be available for an hour. And I said, well, I can drive to Jackson in an hour. They said, well, I could go to the Alpine Clinic or they could get me an ambulance. And I said, no. I told them my name, I gave them my date of birth, and I said I was headed to Jackson and I would like them to get my records ready so that they could be sent to Jackson. I arrived at Jackson at 11 p.m. Afton could not get the info to Jackson. Finally, at 2:30 a.m., I contacted the ER myself, and the lady there was very helpful and tried to help me. She called the tech person, and I don't know what the problem was, but my records did not get to Jackson until that afternoon. And that is not acceptable, I'm sorry. Your population nurse here from Afton, I know your messages are recorded, and I left her a message, and it wasn't very nice, but you need to know that they had been calling my parents several times, and they had been told to stop calling them. And when she received my message, she reached out to me, and I said, she was telling me that this is a free service, and Medicare is going to require it. And I said, you know what, that's the problem in this world. Nothing's free. Somebody's paying for it. And I said, and Medicare is not requiring it. I said, you know what, if you want to help with this elderly population, here's a suggestion. And this is a problem that we're having in our community several times. The doctors are frustrated, so are the pharmacists. Here's an example. An elderly gentleman went into the ER. His blood pressure was in the toilet. He was on 2 different blood pressure medicines. They decided to discontinue one, told him to come back and visit with his doctor in 2 weeks, which he did. And they decided that taking off the one prescription was what needed to be done. Well, a month passes or so, he gathers all of his bottles and goes to the pharmacy and gives them to the pharmacy. And on the one that was discontinued, it has 2 refills left. Pharmacist doesn't know that it's been discontinued. And this happens all the time. I've talked to some of the docs and the pharmacists, and they don't know how to help. But that is definitely a problem in an area that we could definitely help this population. I think it's interesting to note that when Dr. Perks was around, the average, we had no idea what Star Valley Ranch was going to do to the valley as far as elderly population. When that population was here, the general population, the age of Star Valley Ranch was 75 years of age. It's now 46. So it has definitely changed. So now we move to my dad, who was in the hospital at the end of June. He needed to be transferred. And thanks to Dr. Cottom and Dr. Green, Dr. Green stated he was not comfortable doing the surgery. My dad needed to be transported. As I said, I was an intermediate and for EMTs for 20 years, and we separated from Afton to maintain our own ambulances and manage our own funding. We were under the umbrella of the town of Thane to help with check and balance of our funding and also for insurance. We were volunteers, of course, but our charges were only $700 for a transfer. I was surprised a few weeks ago when a young friend told me that he'd been lightheaded and dizzy and had been transported from the Afton Brolin store to the Afton ER, and the cost was $3,000. We paid for all of our training and our supplies, and in the 20 years that I was there, we purchased 2 brand new ambulances with all the bells and whistles. Thane has an ambulance, so does Alpine. So my dad needs to be transferred, but he has to wait. This is early afternoon. We had to wait until the crew and the ambulance returned home from Salt Lake, and that same crew took my dad down to Ogden and did not arrive until 2:30 in the morning. So how long had that crew been on? How many hours? How many miles? Why wasn't there backup staff? You also have 2 buildings in Afton that you maintain ambulances in, and I understand you're renting one. What is your community asking of you? What do they expect for their hospital? What do they want? And I know it's hard to get feedback from the community, and it costs money when you send out surveys and they don't bother to send them back. One thing we did on the school board that was very effective was when we had parent-teacher conference, we had iPads. So while the parents were waiting to see their teacher, they were given an iPad and they answered the questions while they were there. So maybe your people, while they're waiting for a doctor visit, could answer and have a questionnaire and ask some of the questions so you know what the community wants. Because I know that's what your job is. That's why you guys are here. I know you get paid big bucks for sitting on the board because I made those big bucks being on the school board. I'm older than dirt and I am technology challenged. Back in the day, I think the gentleman was Alberto Vasquez, I can't remember exactly his name, he was the CEO, and he needed to come up with a grant, he needed grant money. You remember him, Dr. Kurt, shaking his head, see, he's almost as old as dirt like me. And he was going after grant money and he needed to get community members to do that. And we didn't have anything at the time, and so him and I got some people together in different organizations and we were able to get the community input he needed to receive the grants. And that now turned into the Human Resource Council, and it has worked very well. But we broke off from them because we were dealing more with the elderly population, the elderly and the risk population. So we now meet quarterly. We meet with DFS, and they use this for their adult protection meeting. We meet with public health, home health, it comes, OT, PT, pharmacists, your discharged people here from the hospital come, the population nurse from thing comes, law enforcement, mental health, medical suppliers, senior citizens, assisted living. And it has been a really good opportunity for us to come together to help this population of people. I think your public is really asking for transparency and they want to have some input in this. One of the people that came to your meeting, and I don't know when it was held, they said that you had a meeting and they sat and listened to an audit. And I've been through a school audit and it lasts forever. And it would have been very considerate if a board member had asked them to make an amendment to the agenda and put the auditor who's being paid at the end and let your public speak, because I know a lot of people said they left. I know you guys are working on your billing issues because I received a bill from 2023 and I went up to the billing office at the old Maverick building and they were very pleasant and very, very willing to help with the situation. My question is when I've taken some of my people to the doctor, the providers are telling them, if you need an MRI, go to Evanston. And I'm like, why are you guys outsourcing yourself? Why are we staying with some blood tests? And they said, because we get these people that come back in here and their insurance won't pay for it through the hospital, so we get chewed out. So they're giving them that option. So just a question for you, why can't I have a blood test here? Why can't these people, why are they going to Evanston? Don't you have this equipment? Anyway, I've given you a lot of information and hopefully as board members, you'll do your fiduciary responsibility and looking at the funding, some of the questions, I know you need to ask somebody else to bring that information to you and ask you, why is this way? And I hope you'll take that opportunity to do that. And I appreciate your time this Saturday. Thank you.
Thank you.
Thank you, Eileen. Appreciate you coming.
Thanks.
Kenzie.
Hey, I have a packet for everybody. I don't know what would be best. I just want to pass it down the line. That would be great. Yeah, just everybody. I made 20 of them. All right. So at the last meeting, CEO Dan Ordina said a few things. He said, I see a lot of criticism, but I don't see a lot of solutions. He also said there isn't any grace or pat on the back. He also said we're not going to sit back and have people say otherwise. He also said we're in a lose-lose situation. If we make any adjustment, there's hell to pay. So let me start with this. For all the tension that's been in this room over the past few months, I want to say this clearly. I'm alive today because EMS got to me when I needed them. Because they got me where I needed to go. On October 3rd, 2023, I was T-boned by the Kodiak while driving 55 miles per hour. It took EMS nearly 20 minutes to reach me. I was a trauma level 1 patient. I was pregnant. My 14-month-old was in the car with me. And while I've never complained about how long it took because I understand how the system works, what I never will forget is the care I received. Dr. Cowan, I remember very vaguely, but I thank you. Paul Terry, one of your former supervisors, one of your former paramedics, he was one of the first faces I remember seeing. Jake Bodker, I don't remember him on this call, but I know he gave me outstanding care. Emmeline Marston, one of your paramedics, held my hand while I cried in the back of the ambulance, terrified I was losing my baby, and was patient while I kept asking the same question over and over because I couldn't retain any information. Dr. Hauser, I know he's not here, but thank you for making such painful pregnancy bearable and giving me the birth of my dreams. There are so many others. It reminded me what healthcare at its best looks like, skilled people doing hard work in moments that matter most. And for that, I am truly grateful to the EMS providers and to Star Valley Health. Thank you. You got me the care I needed. You saved my life. You saved my children's lives. But that doesn't change what's coming this winter. And before I go any further, I need to say this. I'm not just criticizing. I'm sick of being dismissed as a critic. I'm not here to tear anyone down. I'm here to sound the alarm. Leaders don't get to ignore warnings just because they're uncomfortable. I've been the EMT. I've been the dispatcher juggling chaos when there's nothing left to send. I've had every ambulance out in this valley all at once, probably hundreds of times. I'm not saying that's never happened before. I'm saying that under this new plan, it will happen instantly. One crash, one storm, one critical medical emergency, and we'll have nothing left. Not because of a once-in-lifetime event, but because the system is stretched too thin by design. That's not drama. That's not criticism. That's reality. Thane no longer has a full-time EMS crew or permanent paramedic. What's left is a critical care supervisor, someone who is meant to be a valley-wide resource, now tethered to Thane to keep it barely in service. But here's the problem. In the winter, the supervisor may be the first and only person on scene. And as highly trained as they are, there's only so much one provider can do without immediate transport. Sometimes the difference between life and death isn't a procedure, it's movement. Getting the patient out of the cold, getting them to care. And one person can't treat and drive at the same time. You've removed the crew that makes that possible. I know how this looks on paper. I know it's expensive to run. I've never denied that, but we need to figure something out. Because in the winter, calls just don't get cold, they get harder. I don't know if any of you have ever driven an ambulance, but doing it in a blizzard with a patient in the back, racing against time, that's a different kind of pressure. I've dispatched those calls. I've lived the moments when there's no one left to send. And yes, call volume drops in the winter, but that doesn't make the calls less serious. Sometimes one call takes 2 ambulances. Sometimes there's multiple patients, and sometimes you're already down a unit when it starts. But what we heard from leadership wasn't urgency, it was dismissal. Chairman Sherbill said, I'm afraid we've spoiled the valley by giving them the Cadillac when they had the Volkswagen. Let me be clear, this valley isn't spoiled. It's not a luxury to expect an ambulance when you call 911, and it's not Cadillac thinking to want someone who can both treat you and drive you out. And now I bring something else. In those packets I gave you are formal letters of endorsement from Alpine, Thane, and I have the Thane Fire Chief here with me, Ted Jenkins, if you want to ask him any questions about this, and the Afton Fire Department, a letter from the town of Star Valley Ranch, and a letter from one of your former paramedics, all asking you to fully staff Thane for the winter and telling you this plan will not work. The Alpine letter carries particular weight because it was written by their current fire chief, but also the same man who is the current successor in interest for Alpine's portion of the 2021 EMS Asset Transfer Agreement. He helped build this system, and now he's warning you it's failing. As for the contract, I'm done talking about it. Even the mayor of Thane told me he doesn't care. And we heard this from Trevor Merritt, your VP of Human Resources. He said at the last board meeting, one of the things they point out in this report, talking about the report that he gave me, if it gets to a point where there's just not enough people, then the burden on a few becomes too great and they will also quit. He's absolutely right. So why, under your leadership, are there fewer EMTs now than there were during the volunteer era? You know the burden becomes unsustainable, and yet you're replicating the same conditions with triple the call volume. I've worked the radio, I've watched the call stack. There's no triage nurse, no software doing the thinking, just one dispatcher, maybe two, juggling fire, law, EMS, search and rescue. Sean Merritt knows this. And when it all goes sideways, the only thing that makes a difference is one more set of hands. You cut that person and now you call it efficient. Let me end with this. When someone dies waiting this winter, don't say it was unpredictable. Don't say it was a tragedy. Don't say no one warned you. I'm warning you now. You still have time to fix this. Please reinstate a full-time EMS crew in Thane year-round. Free your critical care supervisor to respond valley-wide the way they were trained, because if you don't, the hell you talked about, Mr. Ordino, it won't come from your critics, it will come from your consequences. Your window is closing. Thank you.
Thank you.
Nothing.
Chief of Staff.
Thank you, Chairman and Board. Number one, in your packets is the numbers for how many initial appointments, reappointments, and protocols. If you have any questions on that, let me know. I wanted to thank Sean and Abby particularly for last week attending the medical staff meeting. It was very positive. I think it was well received. Incredibly well received, actually. The feedback from the staff is quite overwhelming, actually. So thank you. Thanks for the sugar. And she's still here. So if I can divert for just a second, Jessica, from a medical staff standpoint, thank you. Can't do it without you, girl. Appreciate you. Invaluable. Absolutely invaluable. All right, invitation to the board. These keep coming. So many of you may have interest in what goes on in the OR. And so we would invite you to come join us. Initially, just for a quick little tour, the people in the OR would love to meet you. It would also help you get to know us a little better. Providers, specifically surgeons, we speak a different language. I don't know if it's a good one, but we speak a different language. So we'd like to invite you to come join us. And if you have interest, just let me know, and we can make that happen. Okay. And this will further help you understand approaches to medicine. And it'll help you better understand us and maybe why we do what we do. Okay. So there's the invitation for this month. As you can see from the numbers we talked about earlier, record numbers in the OR, let's start on pace. The record numbers in the clinic setting as well. And so we're seeing a tremendous amount of patients. Let me tell you about our medical staff. And in doing so, if you'll indulge me a minute, it'll help you better understand the way we think. So I'm going to say a name, and Dr. Kirk's going to shake his head yes. Sir William Osler. 1849, he passed in 1919. This is the father of modern medicine. He's actually a Canadian. He was the individual that introduced bedside teaching. Nobody did it. It was hands-on patient care teaching. He created the first medical residency at Johns Hopkins. and ended his career as a professor of medicine at Oxford. He was knighted by King Edward VII in 1911. He has a phrase that those of us that have been through the process know well. The good physician treats the disease. The great physician treats the patient who has the disease. And so when we look at bringing in providers, that is an underlying theme. We're not just going to treat disease. We're going to treat the patient. And that's what a great physician does. And you can't get too far with me without a Wright brothers quote. This one's from Wilbur. It's possible to fly without motors, but not without knowledge and skill. And that typifies our medical staff, in my opinion. And so, Starbite Health is a place where physicians and APPs want to practice. As I finished a case at 2 a.m. Recently with a very seasoned anesthesia provider from Utah Valley. He made the comment, and I've shared this with some of you, but he made the comment, this place reminds me of why I got into medicine. The relationships, the kind of care we give, and treating the patient, not just the disease. So he loves coming up here for that reason. And so at 2 a.m., we're talking about why his 30-plus year career, why did he get into medicine? He says, I lost that a little bit in Utah Valley, but I'm reminded at Star Valley. So those are the things I wanted to share with you. And try to take back the curtain a little bit on the medical staff, all right? And help you understand how we think just a little bit better. And again, we know when you want to come play. We don't take play lightly. It's very serious, but it's fascinating to learn more if you have interest. So, any questions? All right.
Thank you.
Thank you, Mr. Chair.
Thanks. Consent agenda. But I would actually like to pull out the financial results and ask some questions. Anybody else have anything? Anybody have any questions, I guess?
We have a motion.
So is there a motion to support my request?
So moved.
Second? Moved by Clint, seconded by Jeff, that we pull the financial results from the consent agenda. That would just leave the bills of the district. How do we handle that? Do we want to have that motion now, or we come back later after we've discussed financials?
You mean you're pulling it out of the consent? I think the motion is to pull it out of the consent agenda.
Okay, so we then pass the consent agenda, which would be bills against the district only, and then discuss financials, and then have a motion separately on the financials. Is that correct? Okay. I need a vote. All those in favor of the motion?
Aye.
Any opposed? So my questions are just probably to Scott a little bit, I guess. Didn't have a lot of time to review this before I got it, so.
Mr. Chair,
Yes.
do you want to do the report first, or do you want to ask questions first?
Yeah, you could, why don't you go ahead and do the report first, and then we'll bring that into the Finance Committee Subcommittee report. Good idea.
That work?
Works for me.
Do you want to accept the consent agenda before we move on?
So we don't forget it, why don't we have a motion for the consent agenda, which is just bills against the district? Anybody?
Also move.
One second.
A motion by Cole, and a second by Abby. Any other discussion on the consent agenda? Those in favor?
Aye.
Any opposed? Okay. We'll take your report on the finance committee.
Okay.
Maybe it'll answer some of my questions.
I'm not sure if I'll answer, but I just figured that way we could talk about it all and get that taken care of. So, we did have a chance to meet, yesterday as a finance committee. Scott presented he presented and we discussed the June 2025 financial results along with the fiscal year end, numbers, preliminary fiscal year end numbers. Just kind of a quick financial summary. June was a high revenue month, 13.3 million in gross revenue. However, we also incurred some major headwind, or at least one major headwind in June that I was pulling out from the rest. It was basically the non-provider benefits came in $1 million higher than expected. And Scott used it.
What do you mean by non-provider benefits?
Anybody that's not a provider, so staff.
So there were no claims for providers?
No, we're saying that one, that the non-provider benefits, that subcategory was $1 million higher than expected, if you segregate that subcategory by itself.
I think the answer to that is that mostly like primary children's and IRMAC is where money went to, so it wasn't within our hospital system. Is that what you mean, or not?
No,
No, benefits.
So
Like, wasn't that the 401k that we,
no, so this is insurance, and it's
So the
basically
benefit you're
anybody
talking
that's
about
not
is health insurance.
specifically.
Okay.
As I say, it's not anybody that goes to an outside organization. That is some of the stuff that we can't come in, right, as I say, because we had IRMAC.
So this is any of our employees that go to somebody besides our local hospital. Is that what I'm hearing you say?
Non-provider, yes.
What do you mean by non-provider? Our providers are our doctors here, so they're not included?
No, not
They have a
in this
plan.
category. They have
I guess I'm misunderstanding.
The term that is used, the industry term is a domestic claim is where our employees make a claim on the hospital for their care. A foreign claim or non-domestic is other facility, other providers that aren't us, right?
So it's a foreign claim,
It's a foreign claim, they call it a foreign
Versus a
claim, although it has nothing to do with the country.
local versus outside.
Yeah.
Okay,
So, yeah, that, it was more than 2 times the average for the prior year we described to the committee. We were on just over an average per month, about $1 million. And it was $2.2 million this year, or this month in June alone. And it was about 50-50 domestic versus foreign as far as the claims against the hospital, for the hospital to pay.
so our health insurance benefits claims skyrocketed
1 month.
in 1 month. Okay,
We don't know whether it's an anomaly or the beginning of something.
it probably answers my question. I mean, from the end of last month to the end of this month or the end of the year, we dropped 2.5 mil in our net. And you're telling me that's all health related? Claims, pretty much.
Much of it is.
Wow.
Mr. Chair, so if you actually look at the statement of operations, this last one for the month here, so you look at the month of June, benefits expense was 3.3 million, almost 3.4 million. When if you just want to compare that to June of 2024, I mean, I know we're talking about, hey, this was kind of trailing or, at $1 million or whatever, and so it's $1 million more than expected. But if you want to go back to the previous June a year ago, we were almost $2 million more than we were June of 2024.
So you're looking at the actuals versus prior year on the income statement, statement of operations. You're saying 3.3 is this month in 2025, and it was half of that, 1.5, 1.4, 5.9.
No, $2 million.
That's the number you're looking
It's
at.
not $2 million difference, about 1.9, but the majority of it was just the health claims on the district were $1 million plus more than they had been. Secondly, we implemented a new GASB standard that's required to this is in the benefit line, but we have to now provide for and accrue employer taxes on PTO, long-term sick, stuff that's accrued for payment to our employees. Now, so it was about $180,000 accrual on that. And then we.
So isn't that, I mean, aren't we already paying payroll taxes on all that?
Not until we pay the PTO. Now we have to have, on the accrued PTO, we have to accrue the payroll taxes. So it's just another rule, but we had to implement it, and it wasn't a huge amount, but it was a couple $100,000.
Where did this rule come from? Like, give me some background.
Government Accounting Standards Board, GASB, new.
Changed it?
Yeah, well, it's a new one, number 101.
Okay.
And then there was, in addition to that, we had additional amounts to accrue for the 401k matches that hadn't been paid yet. So that's the big piece of that. But a big piece of, most of it's the.
Go ahead.
I think the big part of that though is, of course, knowing that we talked in the past that cost of our insurance plan and some of the benefits have increased. Knowing that, expectations were, hey, we're gonna be here, and we superseded that by $1 million. So I mean, so it's just, the point being is it was, if you go back a year ago, when we talked about expectations, they already built in that it was going to be higher, but it was just that much more, more than even that. So that was a huge hit despite having a high revenue month. Of course, we did end up in the black, 178,000 in excess revenue over expenses. But it could have been much more without the headwind we just talked about. EBITDA for the month, if you add back in interest or depreciation interest expense, I guess just more cash available service debt, 789,000. The short-term debt continues to, there's substantial amounts continue to be reduced. It's continued to be reduced substantially. There we go. Basically, it's down to it was down to 5.2 million at the end of June. And just going back, just a reminder, it was 11.8 the end of March. So you're talking about $6.6 million reduction in a matter of 3 months. So pretty significant reduction that they were able to accomplish.
But then I read in the minutes that we're looking at borrowing another $4 million possibly.
I think that can, about,
That was in the minutes, wasn't it?
Yeah, it was.
The finance committee minutes?
it wasn't short-term money though. They were talking about going to bank, First Bank, I think.
Yeah, First Bank with Mike,
And
yeah.
discussing, because we paid a lot of cash for the equipment
Capital expenses.
and capital expenditures in Alpine, to get that more on a long-term basis, I think is what I understand.
I think that some of that was actually that they were looking into some options and what options they would have available and whether it would be a good option. And that was stuff that we get discussed.
Okay.
So,
Yeah.
Okay.
Yeah. No, and there's
Thank
definitely,
you.
nobody said, hey, let's do this and let's do that. It was mentioned that that may be something they're exploring.
Okay,
So,
thank you, okay.
And as far as days cash on hand was at 53 at the end of June. And again, it did trickle down, but at the same time, the good portion of that was the repayment of the short-term debt, and how much is going on there. So it is still tracking with the best scenario that they provided us and Scott provided back in, I believe it was in March or April, right even. And then the days revenue in accounts receivable, or the accounts receivable days was down 70.9 at the end of the month, and that was coming down from 85.3 in the end of March. So basically a 15. Based on the calculations and whatnot, you can see that's a pretty significant track cash over time. Still estimating about a $3.9 million amount of cash trapped in AR versus a 60-day target. Was that a 60-day target, Scott, or 55-day? 55 day. And then I just mentioned we it introduces new statements, so we can look back over the trailing 12 months. I think it'll be a good thing. There's a lot of information in those statements, but it's, should hopefully allow us to review and see if there's any, big, changes, adjustments that stand out. Hopefully, just another set of eyes on more details and financials. And then as far as our deep dive, we did a deep dive on the inpatient services this month. I think the report's in the packet. If you want more details on that, please refer there. Other than that, I think I'd be happy to answer any questions or anything like that.
Okay, so on your statement of operations, down at the bottom of that, the net revenue day, that's our expenses per day, the 305. That's 1,000. And, well, that's revenue. And operating expenses per day is the 288 that we come up with our days cash on hand, right?
Mm-hmm.
So we've got a net of about, we're positive cash now of about 17 a day.
That's revenue that was recognized, not necessarily collected.
So where are we at on cash inflow and cash outflow?
Well, you look at, as far as a daily, or
Yeah, just on an average day.
no, per week, the last 4 weeks, I look at that by week, just the net ins and outs. Last week was our largest week where we had cash going out more than cash coming in, but in the prior 3 weeks before that, we were positive half a day, negative 0.3 days, positive a half a day. Last week was different because we had several big headwinds. We paid last Erdman's, our retainer was 1 day, basically. Then we had the interim rate review from Medicare came back and we owed them money.
3 quarters.
$735,000.
3/4 million.
We made an attempt to pay that over a 15-month period just to ease our, smooth our cash out. And they said we weren't in enough hardship. So what they did starting last week, was just withhold $100,000 a day that we were getting from Medicare to go against that. And probably by tomorrow or Thursday, we should be even Steven with them on the interim rate review results. So that was the anomaly last month or last week. So we're doing okay. I think we're doing really good actually for the circumstances as far as cash in and monitoring the cash
So
out.
can you add something there? I'd like to see I'd like to monitor that.
Yeah, but just tell me how you'd like to see it.
Cash, that to me is pretty critical right now.
Just tell me how you'd like to see it. I'll give it to you every day because I look at it every day.
No, I mean, on our monthly report somewhere, I guess, on an average day.
Okay, I can do that. You want to just, I can do it a couple of ways.
Take your weeklies and divide by 7, I guess.
Yeah, do that.
Gives me an average day or something. I don't know.
Aren't you tracking that on the PACE report anyway?
I do track the net revenue earned and then the cash collected per day. So if you look at the PACE report, you're exactly right, Cole. That's on there. So our PACE for cash postings per day is on there. In the
Where
middle
is that
of
on the PACE report?
right underneath, it's kind of in the middle of the page. And the first column, which is the current month.
Net cash posted?
Yep.
So that's cash in?
That's cash posted, which is approximate cash in. It's that day's posted. It's the average that has been posted. There's a little tiny bit.
And expenses out?
That's not on here. This is just mostly revenue.
So that's gonna be on, thought we used to have it as a day out on the balance sheet. When we looked at days cash on hand, I guess you can figure it there by dividing.
Yeah, you can. It's about 285, 290, 289 and.
I saw that on a report somewhere. Where did I see it? On this statistics?
Yeah,
Yeah.
you probably saw it was looking, well, it might be, yeah, it's on the statistics one. At the bottom. Right, on the trailing 12 months.
On the last page? There it is.
It's on the first page. So that's right here. First page, first column. show you, net revenue per day. This is again, earned revenue, and then that's annually 305, net
So is the
operating
expense per day, is that cash?
288, yes. Well, it's not, it's close as I can get to cash. I mean, I can do it by minute too, it's really hard,
No.
but by day, that's just the total operating expenses, that's pretty darn close. Because we don't, those are just operating, keeping the lights on, paying payroll and stuff, so there's not a lot of movement in that, like an AR. You can see it by month, the trailing 12 months, the average is 288.
So, Mr. Chair,
That help? I mean, we could do it by month too, if you'd like.
we did talk about getting a statement of cash flow again.
Yeah.
We haven't had one for the last couple of months, but that statement of cash flow is gonna track your cash start to finish for the month, right?
Should, yeah, I just haven't seen that the last couple.
We haven't seen, so we did talk about adding that to you, so.
Probably have it to you in my end of the week, if that's okay.
Okay.
Mr. Chairman, I have a couple questions. Or Cole, do you have more to report?
Not really.
Questions for Cole, Mindy?
I just had a couple questions on disbursements. Elliott Aviation for 48,000, was that?
That was the annual
Oh,
maintenance for the aircraft.
okay. And then US Modular Group, I'm assuming that's the modular building in Diamondville? Okay. And then I had one other question, I don't know, do we rent a hangar in Alpine?
A hangar?
Yeah,
No.
okay. Okay, I had just heard that, and so I just wanted to clarify. Okay,
Not that I know.
okay, we have a house, right, but we rent a house, but not a hangar.
Is it near a hangar or does it have a?
Right.
Sorry, say that, I missed it.
She asked if there's a.
We rent a hangar in Alpine.
Not a hangar in Alpine, but we got the EMS quarters in Alpine, so it'd be the refuge.
Okay.
Probably what it's supposed to ask.
Okay.
Yeah.
We also
That
have a
building-
storage unit in Alpine though, right?
Yeah.
Correct.
Okay. Is it accurate that it's like $6,000 a month, right, housing there? That's just what rumors circulating, yeah.
It's
It's
nine.
9,000 a
No.
month.
Oh, see,
And that has nothing to do with the helicopter, it's just housing for,
just housing for.
That's
For the-
where our EMS stays
EMS.
The
over.
ambulances are parked too.
The EMS, yeah, that's the,
The house is the ambulance and it has a couple bedrooms.
We had to come up with a place when we were asked to vacate the fire station, so.
Yeah, I mean, we talked about this before, Alpine's, for some of the, I think my statement, I don't know, with a meeting or something like that. No, is maybe we ought to be looking at building something, for ambulances in Alpine, because we pay $9 for the building where we store the ambulance and the staff. And then don't we have an off-site housing also, as well as a storage unit? So we have 3 different charges that have to do with providing EMS to Alpine, which just got told we're not doing a very good job of, and it's a big expense.
How many ambulances do we have in Alpine, 2?
Mr. Chair. The one living quarters is for ER staff, not for EMS.
Oh, that's right, it was ER staff. So EMS is just the one building.
Yes.
Okay.
at this center.
And it's, and if I remember our discussion, Trevor and Mike, it was the ambulance garage at the clinic could house an ambulance, but then you've got,
Well, there is one in there
People-
when we went down and did a tour of it, there's one in there,
but they
right?
don't keep it there overnight.
They normally keep the rig with them where they're.
Where they're at. Okay.
Yeah, and that's what causes, if we use the structure we have, which is where we bring people to the clinic, then they're staying at a distance away from the ambulance, which causes response time, so, I don't know what the answer is there, but
I don't either, I
That's
was
a
just
lot per
asking
month.
the question, thank you.
it's a lot per month.
Yep.
Jeremy?
Sure, just to clarify one thing, if the apartment is not used for ER employees, it's used for, a lab employee and other employees who are either taking a 24-hour shift, who are working from there, or we have one employee who works in the lab, and he rents space from us, he does 12 hours on, and then it's 12 hours off, he rents the space from us for that. So people supporting the ER and the whole building, but it's not actually any ER staff, just for the record.
And some
Thanks for the
radiology.
clarification.
That's what I'm saying, yeah.
Yeah.
That radiology and lab.
Other questions?
No, thank you, that's all.
Anything else? Any other questions?
Mr. Chair, just bouncing off of that idea you got, do we have real estate enough there to put up some sort of housing in the ground?
Trevor or Mike?
I'm going to say that at one point, we did have another clinic there that would have been a potential for EMS housing, but we were also asked to vacate that. And so it seems like there's a lot of criticism, but not a lot of support for EMS in that way.
Yeah, we need to read the letter. Do we have real estate? Yes. How many acres do we have, Mike? And
Our current facilities are on just a little over 2.5 acres, and we own 6 3/4 acres.
so a total of 6. We got another 4 acres sitting down there. Jeff, that could be used.
Well, I'm just wondering if I might propose, this sounds a bit like an operational decision that perhaps we should ask management to maybe go through and just review and get their opinion as to what it might be. It sounds like it might be a little hard for us to solve here in our board meeting today.
No, I'm not trying to solve it either. I just, and I don't think we have to, I mean, we can't do it with Diamondville. I'm not sure how we do it Alpine. It's just something that needs to be on our list because I think you could build one for less than 10,000 a month. I don't know, but yes, I agree. And I think it's on your schedule to kind of look at, but I don't think we have the cash to jump into it right now either. So, no, good point, Jeff. Other questions on the finance? That's all I had. I guess I need a motion to accept. What do we do? Accept it? The financial results or approve? So we need another motion. Clint just moved. Are you wanting a second?
Sure.
Motion on the financial results that we took out of the consent agenda?
I can second. I didn't know if you want somebody besides the chair of the finance committee this motion or second.
No. You guys know most about it. Hopefully you're gonna stand by it. All right, we have a motion and a second. Approving the financial results for the 12 months ending June 2025. Any discussion? Those in favor? Any opposed? Okay. Quality Subcommittee report.
Mr. Chair, most of the meeting centered around the 2025 coffee plan, patient safety, and mismanagement. So if it's okay, I'll give my report and then I can approve all three at the end.
Okay.
Just, you'll see on page 34 of the board packet is where the coffee plan starts. I will just say there were no major changes to the plans, but we are required and we do follow through to update those annually. And so that's just where we're lying in the year on that. So just to say, if you've read them in the past, there's no major changes other than some typos and just the minor fixes as far as grammatical things go. I will say, just with this opportunity I have, the public's not privy to the quality meetings. I think it's important to share like what's happening on the quality front with the time that I've been allotted. So QAPI stands for Quality Assurance, Performance, and Improvement. It's data-driven, and it's a way that the hospital system chooses to look at what's happening in the system and find where we can make improvements in quality or safety or effectiveness. And some of that puts us, like it's stacked against other hospitals, but really the way that I feel like it's been looked at is that we're just trying to continuously improve upon our own statistics. And that's more important to me. I would say with a lot of scrutiny on the hospital, like I'm universally hearing a lot of people speak to the care that they're receiving here. And I want to say that what we're doing in the quality meetings is just firsthand, like I get to see why the care is happening at the level that it is, because they're always challenging the goals that they set for themselves. If they're consistently reaching those goals, they're modifying them to ask harder things of themselves. And you know, there's definitely national standards in there, but they're always meeting or exceeding those. Then when it comes to real measures of success, it's what we're hearing back from the community as far as the care that the people perceive that they're getting care. So a lot of the changes that are made, they're self-imposed changes, meaning they're not being forced by somebody to do better. They're already doing the level they're being asked to, and they're superseding that. So I would just say, I can answer specific questions, but like the patient safety or the risk management, they're kind of components to the overall safety and health of the organization and the way that you operate and do things. And you've got those word for word in the board packet if you want to go into detail on what they line out, but where there hasn't been major changes from last year to this year, I would submit that that they're appropriate, they're well articulated, and they do reflect the organization that we're trying to be for this community. Any questions? Mr. Chair, I would submit that we approve the 2025 Poppy Plan, patient safety plan, and risk management plan as written.
It's been moved and seconded to accept the 2025 coffee, is that how you say that, plan? Any discussion? You get the motion and the second, I assume, Andrew?
I do, thank you for checking.
All those in favor?
Aye.
Any opposed? Okay, you want to talk about the next one? You gonna take them individually? What?
So that was it. I made a motion for each of them.
Oh, for all of them?
Yep.
Okay. Anything else? Any questions of Abby on quality? We're down to ethics, compliance, technology. That meeting is when, next month?
I'm still setting it up.
It's gonna be in
We haven't
August?
set it up yet.
Okay.
Yeah.
All right.
Is that just Mindy or are we rotating?
It's Mindy, myself, and Jeff, I believe. Is that correct?
Yeah, I think so.
Mindy is the chair, I believe. We are not rotating that.
Okay.
Foundation report? Is there a meeting? Looks like maybe you, Sean? No? Anybody know about the foundation meeting? Who's
Mr.
the,
England was there.
I
Yeah.
attended
Oh,
it,
Jack.
but I did not,
There wouldn't have been one last month I saw you report, I saw you were in attendance. Like the one in the board packet. That's the only one we've had because it's only been a month.
so there was one in July or not?
Yes, there was, on the
Yeah.
10th.
If he attended, I assume there was a meeting, so.
yeah, there was a meeting, but I guess I didn't really know or come prepared to do a report on the discussions.
Is there anything exciting that happened at the meeting that we need to know about?
There, did we need to bring up before the board the addition of the new member of the?
Lynette Johnson.
Yeah,
To take Mark's place?
no, it wasn't to take Mark's place.
Yes, that's correct. Mr. Chair, the foundation board did interview a potential new member, Lynette Johnson. And I think Mr. England was going to propose that this board approve her name tonight to serve on the foundation board.
Can you give us the background? Who's Lynette Johnson, right? That sounds like a
Dave's
familiar
a
name.
physical therapist. They live in North Bridge.
Oh, that Lynette.
Yeah,
Yeah.
Okay.
Yes.
strongly recommend, I agree with that recommendation.
Lynette attended the golf tournament and volunteered her day that day and got a lot of information regarding the foundation from Jeremy Larson, our board chair, who was there as well. She has a lot of experience in marketing and is very excited to be able to serve. I think she came and volunteered for the half marathon too, so.
On it?
No, she volunteered. She held one.
I meant run in it, excuse me.
No, she did not do that. Not this year.
Okay. All right, so we're looking for a motion to approve a foundation board member, is that right? And Jeff is making that motion, and it's Lynette Johnson,
I'll second that motion.
seconded by Abby. Any discussion on our foundation member? All those in favor?
Aye.
Any opposed?
Mr. Chair, I could help Board Member England out a little bit and report that we did review the investments of the foundation, looked at the return for this past year, and reviewed the expenditures that had taken place this past year in conjunction with raising nearly $450,000 toward the Alpine project. Then the foundation matched that amount that was raised. And so in excess of $800,000 was given to Star Valley Health from the foundation for the Alpine project. So we reviewed that as well.
Fiscal 25.
Right, in fiscal 25.
Great.
Anything else you can think of?
So, what kind of percentage did we make? If I can
I
ask.
don't have that number with me. It was not as good as prior years, but it was in excess of 10%.
Okay.
The only thing other that I would maybe add, and I do apologize for not being more prepared, I didn't realize that was a responsibility I had by attending. I would have been better prepared, but there was a brief discussion around a possible replacement of Mark in that role, whether it's full-time, part-time, and essentially, I think an expression on the committee members that whatever that role would look like, it would have to be connected to some type of fundraising goals in order to justify whatever level that the position would be staffed at. There was no real discussion around what direction to head or even to open up applications for the individual potentially to be involved, but there was at least a recognition that that would have to be a requirement, I guess. I don't know if there's anything more you want to add to that.
You know, I think that's very accurate.
Right now, it's Mike.
Okay. Clint
I thought that position was gonna be absorbed.
was.
Yeah, so.
Mike is now
Mike is-
doing what Mark did.
Well, it wasn't gonna be.
The foundation is discussing maybe they need somebody, is what I'm hearing.
Yeah, just a recognition it's either absorbed or it's gonna have to be paid for by whatever is received. I think it was more just open discussion around what the potential of the future of that role would be.
Mark's position was have to be paid for by the hospital, by the
Yeah.
foundation. So now they're talking about half and they just want to know what that looks like going forward to justify.
And not necessarily having it paid for by the hospital, paid for entirely by the foundation through fundraising was one of the options considered. Pathways discussed rather.
Mr. Chairman, I did mention to the foundation board that with the permission of my supervisor, I'm happy to help the foundation, but there is a limited time frame on that as well due to my imminent departure. So.
Yeah, I think they're just trying to line up long term, like past 5 years.
So I guess we're gonna look for a recommendation from administration at some point in time, is how we handle the foundation.
No, this is a foundation.
It'll be from the foundation. Yeah.
So the foundation will tell us how we can support them and then we'll figure out how to do that.
So you're gonna take that message back to the foundation president?
Absolutely, be happy to do that.
Okay. We have some direction, all right. Auxiliary meeting, were you also with that, Jeff? I have you down. Who attended?
He wasn't able to attend, sorry.
Okay.
Abby comes a lot.
I didn't know that there wasn't somebody. I would have been there. I love those gals.
I know. They're having a card party tomorrow and a bingo fundraising.
About that, like, it's like cards like this. I read those notes and I'm like not trying to step on anybody's toes, but their bylaws do suggest we have to approve a change in,
They
fundraising
used to
efforts.
do those.
Okay, I thought,
Yeah.
if I was like, this feels like it goes way
It's
back,
true.
so I was like, I'll just
It's
bring it up.
something they used to always do.
Yeah, so they don't have to have our approval, it's been approved.
That's true.
I was thinking it was gonna be like thank you card, stationary cards, whatever, and then I read a little more into it. I'm like, maybe I should go.
They also have requested donation requests from departments. And so next month, their next meeting, they'll probably decide what requests to go to the hospital.
Do you know when their raffle ends?
In August 10th or something. So if you guys would like to buy raffle tickets for that big,
I bought some.
so, yeah, good job, Amy.
Were they raffling?
A very beautiful quote.
Will,
Done.
very nice. It's in the lobby at the hospital.
Yeah, there's happy fitness, yeah, there's several different
Yeah, the
things,
action is gonna be fitness membership.
Every raffle in Star Valley has a gun in it.
Not this one, I don't know.
Oh, this one doesn't?
I don't think so.
Abby was saying she thought it was a
I
gun.
the quilt's the big thing.
Alright, big cool. Okay. Anything else on auxiliary? So is this a public bingo night? Is that what it is again?
Mhm.
And it's
That'll be in
when?
August.
August?
I'll let you all know, but
Okay.
the card party is tomorrow, the Johnson Bridge or Ended Book coming down.
Thank you.
Okay. Yeah. Down to our Chief Executive Officer report. Dan,
Yes, thank you, Mr. Chair.
did you attend that meeting?
Yeah, I did. I attended. I submitted a report last week to the board members. I'm not going to go through it entirely, but I'll just touch on some highlights from each of the pillars. From loyal patients, wanted the board to be aware of a discussion in the Finance Committee about our charges. This charges and perception of cost in healthcare obviously will be a topic of discussion, has been for the last 30 years and will be for the next 30 years. So what we've done is we've compared our top billing codes for all areas of the hospital and clinics to not just 3 competitors, St. John's, Ermac, and University of Utah, but we also have looked at a data set of all the charges submitted by hospitals to Medicare. And that tool allows us to take our charges and put them in the percentile ranking, 25th, 50th, 75th, and 90th. And most of our charges are at or around the 50th percentile. Some are around the 75th. We have adjusted any charge that's above the 75th to be at the 75th or below. These are our top billable charges, the most from a volume standpoint, those charges that are utilized the most in our facility. So if you do have any concerned community member about charges, so let's say that there's a concern about, gosh, why does this cost so much? Remember that charges aren't necessarily directly correlated to cost, but we can certainly sit with them and show them these data sets to help them understand that where we line up with those 3 competitors, but also on that percentile ranking of throughout the country. Okay.
So are you going to send us that list or?
Well, it's a spreadsheet. And what do you think the best way to share that with the board? Yeah, we'll send you a.
Similar to the one you already
Yeah,
did.
but I put it on one page. If I could add just a little bit to that.
Go ahead.
So there were certain cases where, we started with the managed care contract kind of guarantee of 10%, right? Looked at that. Like Dan said, if it was over the 75th percentile, we ratcheted it back. If it was under the 50th, I moved it up very slightly, but it would, didn't change the overall aggregate. And we ended up just 9.9 or 9.85 or something percent of, that's the aggregate of those top CPT volumes. So we're right in line with, but it does substantiate kind of a methodology. We moved some up and down, maybe 20% of them. But I'll send it to you.
I did provide some language from the Wyoming Hospital Association about the impact of the big beautiful bill. It is somewhat benign to the state of Wyoming, but as you see, you're going to see over the months how the weeping and wailing and gnashing of teeth of hospitals throughout the country. There is going to be some impact to us, but again, it's not as it's not as of a dominant impact that other states are going to experience. On the service line growth, we are seeing some just.
Before you go there.
Go ahead.
You said provider taxes were frozen in place but not cut. What does that mean?
So provider tax is, it's basically a shell game with the federal government where you give them a certain amount of money and then they give it to you back with a little bit of an increase. And a lot of states utilize this provider tax, and what the bill did is it froze that. And so there is going to be our access to those funds that are then allocated to hospitals in the state of Wyoming are going to be impacted in that way. How'd you like my description of a shell game? I don't know of any other way to.
As good as a Ponzi scheme.
Yeah. So the ED in Alpine, there is a lot of folks that wondered why in the world are we putting an emergency department up in Alpine? And you know, we had some very good, healthy, rigorous discussion about this. And just in the short few months that facility has been open, we have seen more visits than we originally anticipated. We knew that the Alpine facility would cannibalize visits from Acton, and that has materialized. But what it has done also is it certainly has captured more market share because it's a closer access point in the northern part of our county, close to Jackson, close to Idaho. And there are days that we're actually seeing more visits up in Alpine than we are in our own emergency department here. I think medical staff has done a wonderful job of coordinating the care of each of those patients and putting them in the appropriate settings. If you'll recall, this is the partnership of the medical staff and administration, is we were going to put advanced practice providers in that emergency room. And then the chief of staff and the vice chief, Mark Cowan, they came into my office and said, Dan, bad idea. We need to change that. And you need to make the investment into board certified emergency room trained physicians. Yes, it's more expensive. And I know that there were some comments today about, but I will tell you, and the medical staff will tell you, that having board certified emergency room trained physicians with the type of acuity that this valley sees, it is the right decision, it's the right move. And I would love to have any type of education or open debate about why there is such a need for these physicians in our setting. And we really have a good team of emergency room trained physicians that do a fantastic job. And I'm very appreciative of the medical staff for, again, that partnership of working together to put in place a level of care that I think is really going to set the bar for our organization and support this valley in the years to come.
So question on that, I guess, is, and maybe this is Jeremy, or either you or Jeremy, how much more is a board certified ER than a family practitioner with ER training or I don't remember all the gradients.
Just rough
Isn't everybody board certified?
Well, let's be careful because obviously we don't have the numbers in front of us. And I know that,
And I'm looking for approximate. I
yeah,
don't need
Miss Merritt is absolutely correct. A board certified, trained ED physician has a higher salary than a primary care physician. Okay, so I don't want to just flippantly throw out a number. Okay.
So it does cost us more to have a board certified.
It does.
And we have those in both RER and Alpine.
Yes, yes, we do.
Yeah, all of them are that. I mean, we've graduated.
The whole gamut of emergency room medicine is board certified. And it's not just a piece of paper, folks. It's not just a piece of paper. Listen, these people have put years and years of managing emergency room conditions and the way that they think, the way that they handle and manage patients. I'm not qualified to tell you. I would recommend to the board that if you do have questions about what you're paying for and what you're getting, have a conversation with the medical staff. I think they have the credibility to tell you that that was a decision that we made in partnership with each other, and it was, in my opinion, without question, the right decision.
We don't necessarily get to bill a lot differently for a board certified versus a run-of-the-mill ER.
No.
And so at the end of the day, it just makes our profit loss in the ER department different and the care better. It's not, oh, you're paying for that piece of paper.
Mr. Chair.
Oh, please.
So just a thought, and isn't, I kind of look at it as kind of insurance as well, because, I mean, in that from the standpoint that if we were not to provide the best care, it's pretty hard to measure the risks that are associated with having somebody that may not be there, maybe are not able to, provide the best service, as far as reputation risk, as far as just there's a number of risks involved in patient care. It's pretty hard to put a cost on that, right? Yes. But that's kind of what I'm looking at is it's an insurance to make sure that we're providing the best care possible.
Now, with that being said, I don't want to minimize all the wonderful physicians that have worked in the ER that weren't emergency trained physicians. This community, I've said it time and time again, this community has been built, the healthcare system has been built on the shoulders of primary care physicians, and they deserve all the credit in the world to where we are now. And so healthcare systems, they have to evolve, and they have to move in a particular direction to meet the needs of the community and what we believe is necessary for us to be independent, be an independent hospital, grow, and just compete. And I can assure you that St. John's has emergency room trained physicians. I can assure you that ERMAC has emergency room trained physicians. So it's just our journey, Star Valley Health's journey, but let's not discount how important primary care physicians are to our community.
But if we're bringing somebody in, that's a way, the board certification is a way to say, hey, this person's qualified. Whereas how do we vet somebody that's, maybe in family practice that we don't have?
I think they have qualifications in that, don't they? As family practice, I mean, some of them have specialized or fellowships or something. I don't know what the right words are for ER.
Without question, primary care physicians they have the most comprehensive training to handle different scenarios, and this is why they're so valuable in rural healthcare, right? They deliver babies, they can run they can do inpatient, they can see kids, they can help out in the emergency room, and organizations that become more specialized, it's a mixed bag because doctors that are specialized, you only get them to do that specialization, right? They don't have that flexibility when you need it as a community and organization. So there's tension. There's always going to be tension about, well, how do we provide the right type of care, the right level of care, pay for it, and be able to manage every situation. And we have numerous discussions as a medical staff and as an admin team about how to do that. And there's no cookbook that tells you how to do it. We just have to have ongoing discussions about where do we go next. And there's going to be disagreement, and I respect that. I know that there's strong opinions one way or the other about what the right decision is. But as for me and where we are right now, having 2 emergency departments and our population growing, I feel very good about the level of care, safety, the consistency with our emergency group.
No, and what you're saying is we're having it's the certificate though brings our level up, but we're still charging the same amount whether you show up in the ER. I mean, the charges haven't changed. Our costs have gone up, but hopefully we have a higher level of trauma availability, I guess, right? So the question that comes to my mind on this though is, so our EMS is an extension of our ER. Is the medical staff saying the same thing? Is that we ought to be staffed to the hilt with paramedics and things out on, and maybe more than 3 sets? I mean, to me, it's the same discussion here. We chose to spend the money on board certified ERs to have a better trauma experience or whatever. So isn't that discussion going to come into our EMS discussion?
Well, so let me make sure that on record to address Kenzie's concerns. I want to make this very clear. Star Valley Health does not have to be involved with EMS. We chose to do that to make a difference in the community. And my words is, if you're damned if you do, you're damned if you don't. And it was a choice that we knew financially was going to take a hit. But we also felt like if we didn't step in and help, the deterioration would continue. And if anybody says that volunteerism was going to somehow save EMS, I completely disagree with them. And there could be lots of volunteers, but when it comes down to the actual training, the actual response times, we have elevated that significantly, and the data shows it. We provided the reports, so it is. These are facts, and I want the community to know that we want to be of help to EMS. We're certainly the ones that are being criticized, and so the right response to all of this is to get all the stakeholders together and the community decide where does it go after this contract's up.
And that's November 2026.
That is going to be, yes. No, it is November 2026. Yeah. I was thinking, sorry, I paused.
No, it's fine.
I paused because I thought I was thinking January of 2027, but.
So on this topic, next question.
Yes, Abby.
What if a community like Alpine, I feel like from everything, the signs that I'm reading are that they want control of their own EMS. What does that look like for Star Valley Health if we don't make an agreement that they just take EMS operations over for the community?
Yeah, so again, I think I don't have the answer to that. All I can, we have the frame of reference of what EMS looked like when Alpine had their own organization. They had their own. Afton, back in 2008, had their own before they said, hospital, please take it over. And we brought it together, we've elevated, and now the question is, what do we do with it now? And I appreciate Kenzie's passion, and I can see why it is so important to her, especially from her own personal experience. I don't want to in any way minimize that. But I think that if there's going to be any criticism, that criticism needs to be directed towards not individuals, but what is the solutions to problems for the community. We were a stopgap measure. We're not going to be able to just sustain this on our own. We want to be part of the solution, not part of the problem. And the right next step, which we're putting together right now, is we've met with them individually. We'll bring everybody together. And I fully expect that these organizations, these stakeholders are going to, we're going to get some good ideas, and we're going to figure out what does November 2026 look like. And hopefully it's a solution that the community can accept. But I don't believe that, I believe that Star Valley Health is being unfairly criticized for what we're trying to do for this community. And I'm not saying we manage this perfectly. We don't. We make mistakes. But Star Valley Health is a tremendous asset to EMS and a tremendous asset to this community. And I don't apologize for that. I think that EMS would be in a very, very dark place right now. And as evidence, look at Cokeville, look at Kemmer, look at other locations in the state of Wyoming. It's not working. And you can't refute it. So I appreciate the level of passion, but let's not focus on individuals. Let's focus on solutions with the right stakeholders, and that's the right approach to this whole issue.
You can go first.
Sean, yeah, thank you. I read all of these, and I think all of them are worried about one person thing. Like the general worry of everybody, and he's gonna have a concert, just real quick.
Yeah.
And whether, I need to be careful what I say and think about it, because I don't do that very often. So all of these letters came from fire chiefs and EMS and stuff like that. Their big concern is that we're getting one employee off the call line for half the year, right?
Possibly.
Because that's what we're doing during the winter. Is that what it was? The winter, we're going to kick back and we're going to put the one paramedic there and then kind of roundabout help. So they're really, all of this is because of one employee in thing. It sounds like to me, and I could be wrong. But that's what I'm hearing, is that it's one employee thing. And I know you can't just throw money at things and fix them, because you'll run out of money. But I also heard a couple of members, when we had 100 people from the community here, talk about how EMS had an open checkbook at one time. They were spending money on all things. And we really looked at EMS to really try to say, let's consolidate a little bit. Let's see if we can cut enough fat off to keep that one person there for 6 more months. That's so easy. Because to me, if that's the fix that I'm seeing here, it shouldn't be that hard. And I know I'm not the money guy. I know I shouldn't be, it's like, what does it cost to have that EMT on for a full year instead of half?
It's not that he's on full half. I'll let Trevor answer, but it's a position. It's like putting Dr. Cowan in a cubicle in office while there's people that may need him in the surgery or orthopedic trauma. It's a position that's supposed to be floating depending on where the emergency is. True? That's what I understand the position to be.
That is what the supervisor, Mr. Chair, can I say that?
Yes, sir.
That is what the supervisor has done in the past. And this recommendation was actually made by our director and our supervisors together, because they felt like it was an opportunity for us to make some savings, and they felt like it was something they could manage.
Did they feel like we were gonna have less service?
I think that they had concerns regarding the busy season, and that's why we have tried to address that with the seasonal employee.
So by keeping that seasonal employee year round, it seems like that solves a problem for everybody here. And if that's the problem that some of these people are talking about, like we used to lease the building from Alpine Fire Chief, right?
Yeah.
I don't know what happened. I don't know what happened.
Something weird happened.
Is this a big enough change in something that we could revisit the fire chief and be like, hey, you're telling us there's a problem. Help us fix it. You know, if he's saying that, yeah, he said that you're spending $9,000 on a hangar. Okay, well, help us fix that. Offer us your fire station. Let's move back into I can't sit here and tell you guys what to do, but I really think that to keep one employee for 6 more months, that's a very small amount to make some pretty important people happy.
Well,
that's all I have.
So no, and Sean, I hear you. What we can appease people. All of our tax levy is going towards this,
Awesome.
which has been reduced by 25%, plus another $1 million. We can appease the public and say, okay, here's your staff member. Has it solved the problem? No, it's still unsustainable. So really what has to happen is everybody wants a staff member, right?
I'm not asking just to throw a staff. I'm asking to maybe communicate again with Alpine, because I know they're not required to pay X amount of dollars for EMS services. I know Fate isn't required to. I know Athens is not required to, but this seems to be a big enough issue that maybe it'd be a good time to revisit some of those people and be like, hey, these are the stats, these are the numbers. And I guess instead of just saying, well, they won't help us, maybe ask for help.
No.
There is,
That's
am
what
I
one of
missing
those
something?
upcoming meetings.
Yeah, so I've met with all of these individuals. This is not a communication issue. This is, we're gonna bring them to the table, and we are asking for their help. We are asking for their input about how we're going to solve this problem. And so I think that's where we are. I don't think it, I could have, we could throw some more money at this, and just so that we don't get the criticisms. But I think the undergirdings of this whole issue is, how do you pay for it in perpetuity long term?
But this was decided in 2015, right?
Go ahead.
This was a contract established in 2015. Or how long ago was this contract?
No, it was
21.
Recently, but the community's evolving, so like we can clearly see based on response times and how people are coming and presenting to the ER for the surgery they need, we're doing a great job. It's just looking at, now we've reached a point of, we've got to readdress it. And you see that, it's just funny, like the communities are like, oh yeah, we'll turn that dead horse over to you and like just take care of it. Well, like the contract's only a certain length of time because we do have to relook at it. Like maybe they're responsible for housing and where the ambulance goes, and we worry about the staffing issues.
And that's the whole beauty of bringing the stakeholders together.
And they've said yes, they're all coming together.
So with our ER, we didn't bring any stakeholders in to decide what Alpine was going to do. We talked to our medical staff. The point I'm trying to make is medical staff came and said, we got to have board certified ERs down there, right? And we need them here. And we took the brunt of that. I don't see any stakeholders that we're talking to it about. Why is it any different with EMS? What's the difference? Because we made a choice with ER, or do we have some requirement as a hospital to have an ER?
Yeah.
In Alpine, we had a choice, right?
Yeah, but
we didn't have to even put it there.
Well, what I'm saying,
correct?
What my point is, Marlo, is EMS is not viewed typically as a hospital department. It's not.
Okay.
It's
But it's the same discussion.
No, it's not.
Oh,
It's
it
not.
is.
No, because when you're dealing with the whole operations of a hospital, you have to consider the ER. Now, did we make the decision to elongate a hall and expand our ER to Alpine? Absolutely. But that's just a continuation of how we operate the ER here in Alpine. So I view EMS and our operational decisions and who's involved with the ER totally different than EMS.
I am not today. I was, but it sounds to me like it's somewhat the same decision we made for our ER in Alpine. And I think that's what the community is going to expect of us.
But they need to hold their mayors accountable to that, not just the hospital.
Why are the mayors responsible? Clint?
Well, because this is, I agree with Dan that EMS is not an obligation by the hospital in any way, shape, or form. So when you look at it that way, I always look at that we're paying Thane $2,400 a month rent to park our unit there.
Could be a dollar.
If they're wanting to help, that's 30 grand a month, just park there.
A year.
That's 30 grand a year.
Yep.
That's half the salary of a intermediate EMT. So yeah, I think these communities need to, EMS is not a right. Healthcare is not a right. It's not a right for anyone. It's a business. And I know that sounds harsh, but it's a business. And we have to make business decisions, and if these communities, if there's this shortfall and there's this need, well, then it's gonna take a lot of minds to come together to go, how can we have this in our communities? And yeah, the mayors need to come together, and yeah, they better start scratching their head, or else, because like Dan says, this isn't feasible long-term. It's not sustainable money-wise. I'm passionate for EMS, don't get me wrong.
I understand. Jeff, you had a comment?
Well, just still trying to learn, so I think I understand that the EMS is not the same, and not really a hospital responsibility, except that there is an agreement in place, is there not? And I'm just wondering sort of who the parties of that are, and does the community view, if there's an agreement in place, that is a responsibility that perhaps doesn't naturally fall with the hospital, but because there's an agreement in place, you've essentially taken on those responsibilities.
Yes.
And so that's perhaps where the public perception, regardless of what reality is, if that's the perception, that becomes a public reality, I guess. So just kind of curious how that agreement fits into place with what you're saying.
Yeah, so the state, to answer your question, the stakeholders are the town of Alpine, town of Thane, the Star Valley Ranch, the town of Afton, and the county. Those are all the stakeholders.
Town of Afton isn't on that agreement.
We have an agreement with them. They're not on this one that was 2001.
Yeah.
We have an agreement.
So we have a separate agreement with the town of Afton. It's a similar agreement in that they worked with us to provide us with assets, and
This was back in
this was
06,
2008,
08.
that agreement was signed.
Hasn't been updated, and so we're committed to, guess I need a copy of that one, I haven't read that one. We're committed to doing EMS for the town of Afton forever without any compensation. Is that?
There's no term on it as far as that goes, so.
But ideally, it would be put under the same umbrella if we reestablish a new contract. The towns up and down the valley would be on a similar contract.
Yeah. So I want you to know the direction that we're headed, who's going to be involved, who we're going to communicate with to come up with solutions about sustainability. And that really is the best next step to, figuring this out.
So would our medical staff say, we don't really need a EMS?
Well, I don't know. I don't want to put Dr. Cowan on the spot, but
we just found out that we need an ER in Alpine. They made the recommendation that we have a type of quality of doctor. And I guess to me, it mixes the same thing. The EMS is it's the outside arm of the ER, isn't it? I mean, that's how we bring patients back to our hospital. And so I see it all tied together, but maybe I'm not seeing it right.
Do you want to ask a question?
I don't know. Do you want to answer a question? So how do you see EMS in ER or ED or whatever you want to call it?
I think one of the first comments is the medical staff doesn't have any experience with a hospital running an EMS because it doesn't exist. Only here. It may exist other places we've never seen.
Oh, I'm not following you.
Hospitals don't run EMS.
Okay.
Except for here.
That's my point.
Yeah.
So we don't have experience with them. And so typically from a trauma standpoint, from an ER standpoint, you see these individuals, but there's not a relationship there. They are truly separate in the world. Now here it's a little different. We're a small community. We've got relationships with these people. That's a good thing. So I think the comment by Ms. Merritt, is it Merritt? Merritt. Just a piece of paper. That one's concerning. I wouldn't pretend to understand her business. And she obviously doesn't understand what that piece of paper means. It means a lot. I'm trained in thoracic surgery. Should I operate on somebody, do you want me? No. You want somebody that does it day in, day out. With respect to the ER, our ER providers, as I poll them on a regular basis, are impressed with the level of acuity, with the high level that's being required in Alpha. And it would be like me saying I'm a cardiothoracic surgeon. Not, we need those individuals that have those particular skills. And so, right decision, yeah, because we had one opportunity to get it right. We got it right. I won't back away from that at all. That does not mean those that came before are invaluable. Absolutely not. We each have our skills, and I don't pretend that me to do family practice. You don't want me doing family practice, you guys. So again, we don't have experience with it. It doesn't exist. And I think that's critical. I think what's important to remember, though, is that, number one, are we upholding our end of the contract? Yeah, we are. Number two, are we taking good care of patients? Yes, we are. Exceptional care of patients? Yeah, we are. I don't think we should lose sight of that as well. Not sure that answered your question.
It answers my question, and I agree with you that we're taking exceptional care. That's good. I definitely agree with that. My last comment was, so when you compare June volumes 2024 to 2025, they're basically the same. So you made the statement that we were increasing.
Yeah, so.
And I just didn't see that on the chart here.
Yeah, so May you would have seen that significantly increase. April, you would have seen that significantly increase.
Where's the increase? Last year was just over 400.
So I just isolated.
Total this year is over 400.
So last CEO report, I provided May volumes. You could see that it was in record months. April, you can see record months.
You're saying June is almost the same.
June's about the same. June's about the same. But overall, you take these first 6 months of this year compared to the first 6 months of last year,
We're capturing more emergency room visits.
No, I was just looking at your June chart.
Yeah.
Thank you.
Mr.
I
Chair.
don't see it. Did you have a question, Jeff?
Well,
Or
yes, I did.
comment,
It's
and then
kind
we'll
of,
go to
it's kind
Scott.
of related to what you were talking about, so thank you, Mr. Chair. I had the same observation. It seemed like the June totals were about the same, but it's kind of split between the two. So just think you help me understand sort of the business side of that. As a critical access hospital, I think there, as I understand it, we provide the emergency department and whatever the costs are associated with that combined revenues were made whole. Does that apply with additional emergency departments as well? In other words, is there a business risk with building it out and staffing and having lower traffic through both of those if at the end we're still made whole by providing an emergency service? Does that question make sense?
Totally. Yes, it is. It's one of the headwinds that we've had to deal with financially this year is replicating 2 EDs and all the services to support that ED up in Alpine. So starting a new location, hiring more people, salaries going up, significant business risk. I think that we've managed that headwind fairly well. There have been some cost overruns with some of the the timing of the hiring, training, and opening of that clinic up there. But what we do get is with Medicare cost report, we can take the square footage of that emergency room and we will get a portion of cost reimbursed back to us through our cost report.
So the overall facility has some exposure.
Yes.
But the emergency department piece is made whole because that's what's submitted in the cost report.
I wouldn't say it's completely made whole, but the risk is minimized through our cost report.
Much smaller compared to the other services offered there. Yeah, thank you.
How much will we lose in our ER and Alpine when it's up and running after 5 years?
I don't know if we had the pro forma out to 5 years.
Well, even 3 years. We're gonna lose money.
ER?
Yeah.
Yeah.
ER lose money.
Yeah.
So-
Probably, yeah.
Wait, just typically, right? $1 million?
Yeah.
I don't know.
Okay.
Try and answer them.
Okay, so that went a little bit longer than I thought. I also want the board to we talked about this in the finance committee, is our cash position, we have been tracking towards our best case scenario. I think that the team and the organization as a whole have done a very good job of being disciplined with managing cash. We're still in that very disciplined posture, namely because we know that once we eliminate the payments to Optum and the short-term working capital note, our cash position can take a very strong reversal. You've seen the millions of dollars that we have paid in just a short amount of time of where we are now. But paying it off is one thing, but then building the reserves, we talked about that. So we anticipate at the end of this month, the note to be at a balance of about 2.5 million.
Plus or minus, yeah.
Plus or minus, okay. We anticipate that based off of our payoff level at 20% with Optum, that hopefully we'll have that completely paid off by the middle of September. And then as Scott has mentioned, is we then per week, we can add 1.5 to 2 days per, depending on our cash collections, 1.5 to 2 days per week of days cash on hand. And then over time, we manage that to get to our, not just to meet the covenant, but where everybody feels comfortable with where our cash position is. And that was the plan all along, is told the organization, hey, we need to pump the brakes. We need to fix the fundamentals of billing. collecting, and any other ways that we can streamline the operations of the organization to preserve cash. And the action plans are working. We still have some headwinds that Scott has already addressed, but we want the board, the dialogue that we had with the finance committee, it was a very healthy one where, we looked at different options and what about this, what about this? And so I appreciate the board engaging, asking questions, giving us your direction and counsel, because it's a team effort. And I know you care greatly about the success of this organization as well as everybody else. And we just want to do the right thing. And we want to make sure that this is a community asset that is just glowing. And we feel very bullish that, in the next month and a half, if we continue on our trajectory, we're going to turn that corner, and we'll get in a position where we can get back looking at some of our growth strategies that we had discussions previously. So that's in a nutshell, my report. The other thing, lastly, I did want to make mention and congratulate the organization for the wonderful involvement in the half marathon. We had numerous employees volunteer, giving their time, and the Coon family, it's a bittersweet thing for them, and they know that our organization has the wherewithal to carry on the spirit of what they created 15 years ago, and we're already having conversations. Okay, what do we need to do in the month of August right now, and what do we need to do in September? We don't want to let them down, and we want to carry on their legacy. And we feel very honored and humbled that they would consider us to carry that banner going forward. So, but it's a great event, and it's again part of us being the fabric of the community. Any questions?
Okay, review of last year's goals or this year's goals.
Yeah, so in your packets, there is this little chart right here. It looks like this, the grid. These align with our pillars. Just to give a little bit of context and backdrop, you'll recall that we used a company called Gallagher to look at how you establish goals for the CEO, which I in turn established for the entire admin team. And so this was our first year of getting this, I guess, using objective data to measure our progress. And we've learned some things in this first year of goal setting. But as you can see, there's 2 goals in operational excellence, 1 in loyal patients, 1 in best people and culture, and 1 in service line growth. The goal descriptions are there. The first being the financial. We wanted a target of EBITDA of 8.5 million. Based off of our financial results, we're going to come short of that. Right now, the unaudited EBITDA is just above 6 million. I've made a recommendation to the board chair to wait until the audited financials do materialize, so that there's not the because of this past year's audit and some of the uncertainty. I think if we're going to have discussions about whether or not we get credit for accomplishing a goal, I think it needs to be, we put unaudited financial statements on this one, but I think we need to look at the final audit going forward. That's goal number 1. Goal number 2, on quality, we've been working with the QSOC committee with process improvement projects. We wanted to to really make process improvement part of our culture and get a lot of people involved in helping with patient care. And so there's been some great projects that have come through. We've accomplished 5 of those projects. And we can certainly give you, we've listed off details in previous reports of what those projects were. And if we need to provide more information, we can. Loyal patients, Epic, the benefit of Epic is, one of the huge benefits of Epic is the use of MyChart for patients and that interface. We knew that you could establish Epic, but if you don't get people signed up on MyChart, you lose that stickiness to the system. And so we really made a concerted effort this whole year to move from 30% or it was even below 30%, to try to get to 34% of patients using Epic. Because of this push that said, hey, we're going to measure this, we're going to talk about it, we're going to track it, we're now up to 42% of our patients that have signed up for MyChart and are utilizing it. And then the fourth one, best people and culture. We believe that leadership is the key to helping attract, retain the best talent, and we've invested a lot of resources into Gallup's Q12 program and the training associated with that. As you recall, we're using the Q12 Gallup survey for our engagement. We'll be doing another survey come January, and we have another goal that we'll propose for this upcoming fiscal year in that area. We wanted to make sure that we at least got the department directors and managers, 85% of them trained, and we have exceeded that goal to 95%. And then the last goal of service line growth, we looked at outpatient visits within Epic. We felt like that would be a good indicator of us reaching our financial performance with earnings. And we had, I believe, a 3% increase there for outpatient visits. We exceeded our target of 72,000 as well as what we thought would be a stretch goal of 73,000. We exceeded that by 867. And so goals are really meant to place an emphasis on what's important to the organization and where the board wants us to really put our time, energy, and effort. And so that's a good segue into what the write-up that I provided to the board on just a proposal of what this year's goals should look like. And really, this is meant to be a dialogue with the board. We're not saying that you have to go with these, or we think very strongly. We want your input, but we have listened to medical staff members, we've listened to our directors, we've listened to board members, and we really believe that our financial goal should be at a minimum the debt covenant that is now in place of 80 days, at a minimum. Our target should be over that at 83, and a stretch goal would be to 85. We're currently at 50, so we want to add in the next fiscal year 30 days of cash on hand. And we feel like if we're disciplined and we approach this the right way, that we can get there. Then on quality and operational excellence, we believe that in a just culture with our employees, we don't want our employees to in any way feel intimidated or there be an element of fear. We want people to just speak freely about how they feel about a given situation. And we've made a lot of progress thus far in emphasizing this. But we can do better. Last year, we only had 26 documented good catches. And what a good catch is it's identifying and documenting an event or process that could have resulted in patient or employee harm, but did not because someone spoke up. And hospitals that have a culture where they can just speak up and express their concerns is a very healthy hospital. And that's where you start to really catch and avoid harm. And so we really want to stretch ourselves and have a minimum of a goal to get to 75 at a minimum, good catches, a target goal of 100 and a stretch of 125. And if that were to happen, I think our organization would then just really take a gigantic step forward in process improvement. I think that they would have more confidence in feeling like, hey, you know what, I can make a difference in the improvement of the care that I provide our patients. And so we really want to make this an educational effort for our staff is tying quality to good catches. And a lot of other things can flow from there. Loyal patients, we believe that the presumed number one dissatisfier is our billing process. And that's anecdotally, okay? There's enough anecdotal information out there that tells us that. But the fact is that this hospital doesn't have, and nor have I ever been part of a hospital that actually measures the billing experience. There's very few hospitals that actually have focused questions about each of the process of billing. And the reason for that is there's much of it that does take quite a bit of time. And there's much of it that's outside of the control of the hospital because you're relying on billing, you're relying on insurance companies to get you claims processed, not deny them, get you correct information. We get them correct information. But we feel that this is something that needs to be put in place going forward. You can't improve what you don't measure. And we feel like, based off of some other conversations with board members on this topic, that our organization really needs to prove to the community that, hey, we want to improve this, and here are the areas that we're measuring, and here's how we're doing. Are we winning or are we losing when it comes to billing? I don't think it's fair to the organization to just base billing off of the various experiences. I've heard bad experiences. I've heard good experiences. So which is it? Well, the ones that are usually the bad experience, they have the loudest voice. And I think that there's a lot of other patients that actually do have a very benign, pleasant billing experience, but we don't talk about that. Now, can we improve? Obviously, yes, because it's such a hot topic of conversation, but we have to be able to measure that to really prove and post our numbers up that we're moving in the right direction. And so this is kind of an all or nothing goal. And it is going to take some time to implement, and it's going to take some effort to really put in place and then start disseminating the information. But the team felt like if we want to, this should be a priority for the organization. That's people and culture. We have invested, like I mentioned previously, significant resources in Gallup training, Clifton Strengths, and the Gallup 12 Employee Engagement Survey. Like I mentioned before, we're going to complete our second Gallup 12 Employee Engagement Survey in January. And then based on these results, we recommend that the departments using that training implement formal action plans off of the baseline that we had last year to this new survey. And then we have two points of reference. And to get each of the departments, the leaders and the employees to talk about, hey, what is the question that we want to work on? What's important to us? And allow those departments to then form goals and work on their what they feel is a deficiency in their department, because every department is distinct and it's unique. And what is working well in pharmacy may not be working well in med surg. And so you've got to manage employee engagement based off of their microcosm of what they believe their work environment is. Hospitals are known for being siloed, and they truly are. And the toughest thing to do is to break down those silos and have a consistent employee experience, because based off of who your direct report is, the workload, the situation that you're trying to manage, you can have very different responses by employees. And then lastly, service line growth. We're going to expand the definition of outpatient encounters. We want to include not just outpatient visits, but ED visits and outpatient surgeries. And similar to what we did this past year, we want to tie it to what the assumption that we put in this past fiscal year's budget of a 2% growth rate, which would then mean that we would need to get to, as a minimum, so if I were to add up this past fiscal year, all those three together, the number is 80,899. And we want as a minimum to exceed that at 81,500. But the target goal should be what we baked into the budget of 82,500, and a stretch goal of another 1,000 of those encounters at 83,500. And so those are just an annual review of the goals that we had this past year, how we would like to take what we learned from Gallagher, their recommendations, move it forward, with the caveat that the board needs to have a discussion somehow, some way, about whether or not we got our ladder up the right wall. And you need to help us as management to understand what is important to you and where you want us to put your focus. So really the levers are, your two levers are the goal and then how much you weight that goal. So we made recommendations of how much you should weight. And really our recommendations are coming from what was provided by Gallagher. That's kind of the industry standard in hospitals, is here is how much finance is weighted, how much quality is weighted, here's how much patient satisfaction is weighted. So all of those things have gone into consideration in us making these recommendations to the board. Okay? And I'm not saying we have to have that discussion now, Mr. Chair. I think that there might be different avenues for the board to engage in this process.
So let's take a 5-minute recess while we think about how to engage in it.
Okay, sound good.
So I recorded this and but I kind of want to make sure I got that.
Oh, yeah, I should have been pretty good.
Yeah, John. You're talking about you sent me the report. Okay. Yeah. One of the stars.
Here, put it right there.
Okay, great.
John and this media. Great.
Yeah. Yeah. You have it. I don't know.
Maybe that's what I'm like.
So you just.
There you go.
So what do you want?
We'll go wide. Right. I thought it was
Right, because we're gonna post some of this out there.
Okay.
Yeah.
Hey, I'll take coffee as long as I get a hot cup.
This is the one that we had like years, 12 months. Last year. Showed the different measures.
Hey, you know what, we're still doing that scout. I get this stuff.
That was a great man.
What's that?
That was a great one. Let me look over, make sure.
Well, I didn't say how far we were. Actually, like I said, they're all gonna be lined the walls with flat hats. Come on in. Sell your organs. I promise, it's not gonna hurt, I promise. You're not gonna feel pain.
I'll send it to you.
Where's the board? He's still over.
Don't worry, that's
Yeah. So.
That's too funny. Ken's gonna do that. Go.
Oh, yeah. She might want to scout too. I don't think
She would, overwhelmed.
You gotta wouldn't like piss her off, and that's for
It's dangerous to keep you in trouble.
I wish you understood my parents and I can tell you that.
I'm way up on
both those. That's my yeah. So.
Well, I'll send it to you. I'm gonna keep it in case there's a question.
Nice to meet you.
Thank you. Appreciate you.
I found out she was doing this through, I was like, I just purchased. I said, I got my ass cheeked.
She stopped in and talked to me.
So it's really funny, because I asked her a question, how many other kids have you? She got quiet, and was like, yeah, you won't talk to your son.
Well, she stopped in, she's
I think that's a good conversation for you to have.
No, it was not, it was 40 minutes and then yelling.
So it's not a good conversation. It's just.
What did they do?
Yeah, I don't know about that happens, but no, yeah.
That's a funny observation. She probably was showing. She has been sometimes like, well. She's been there.
That's okay.
The only critical thing was.
All of a sudden, you're in more trouble.
That's okay. I like that.
Talk to your father-in-law. Oh, yeah. He's got things.
I know that.
Let's talk about that. It's pretty awesome.
No, I think that's a good comment.
I literally.
I got 5 hardships.
Say that again?
You're unmuted.
Okay.
All right, we're gonna call the meeting back to order after our 5-minute break. So I guess the question for the board that I see, there's two. One, we have a report for the year of ending June 2025. This is concerning the incentive compensation plan. And then we have proposed goals for 2026. So tell me how you'd like to handle this, board.
Decide right now, can we think about
On
it and
which?
decide at the next meeting, both of them?
On both of them?
I don't know.
I guess, I don't, is there a time constraint on any of this?
We would like to, in the future, to answer your question, no, but in the future, we've got to figure out a more effective way of communicating the organizational goals to the organization. And right now, we're just completing all of our performance reviews. And, you know, these goals are also meant to help give some direction to the rest of the departments about, you know, what we're trying to accomplish. And then them being able to, you know, how we went over the strategic plan where we give them a goal, and then there's supporting goals or supporting strategies, and then questions to connect their department to the organizational goals, so there's alignment. August would not be a problem. We just wouldn't want it to go any further than that, because people are already trying to establish their annual goals right now, and we want to give them the opportunity to establish them as soon as possible.
Maybe I'm the only one, maybe everybody else is ready, I don't know.
So, well, let's take the first question, and that's, at least as it goes down in our agenda, is we have the review of the goals for last year. And actually, those might actually come in under discussion in executive session, because all we're doing is looking at goals for the CEO.
Mm-hmm.
Even though these are organizational goals, our CEO gets to decide whether or not the organization has accomplished the goals to the satisfaction. That's the way I understand it. Does that, anybody else have a different idea of that? So what we need to do is probably discuss the current goals that were completed as of the end of June. I think we move that to executive session because that's personnel. Would you agree, attorneys, so that I'm not sending something that I shouldn't to executive session? Okay. So.
Can I ask something that shouldn't be an executive session, just a question? Mr. Chair?
Yes, you can ask any question.
Well, I felt like he was asking the question of, should we be aligning the goals with far enough down the road past the final audit? Mm-hmm. I felt like you kind of made me think that would be a good idea.
Oh, without question. I think.
And do we have to be doing this in July?
Well,
that all the organizations would know that we actually look at the final audit and then make the decisions based on that. That would encourage the audit to get done timely, and it would be real numbers.
Well, there's a couple ways you can handle it, right? Is you can.
I think that would.
There's certainly. That's fine. There's certainly goals that don't depend on the audit.
I agree, but the way you lined it up, you acted like the top goal was the threshold for all subsequent goals. So even though they're showing green, you set that up with a financial trigger, which would lead to maybe an audit issue.
You know, I didn't mention that. You're absolutely correct. And really, you know, again, this being the first year, we established that trigger that, you know, net income would be positive. At the bottom line, positive. The board has the discretion to change that, whatever the trigger you want it to be. I mean, we're not like, all I want to make sure of is that the CEO goals, the organizational goals, the board, we're aligned. And however that can happen, that's the most important thing to me.
So I think for our agenda today, we're gonna move the discussion of the CEO goals for ending June 2025 to executive session. And we'll finish it there. And so my next question for the board is, you want to discuss the proposed goals for June 2026, ending June 2026 today? Thinking about it? No, I don't think so. I don't know. Those, to me, those are organizational goals, even though they're tied to the CEO for us. I don't know.
I mean, the trigger that allows it to be in executive session is the personnel aspect, right? So personnel performance review, so we're in review of last year's goal, right? That's tied to his compensation and his performance.
It's all executive session.
So, you could set the goals outside of executive session. If you wanted to, you could probably do them in as well as performance measures that you're setting. So it's probably.
So I guess the question then is, for the proposed goals, which will end in June of 2026, do you want to discuss those in open session, or you, as a board, feel like that's more of a executive session personnel discussion? You're thinking personnel.
I think so, but.
I think our discussion in regards to the CEO's goals needs to be executive
This
session.
is all kind of mixed up, guys. It's
Right,
CEO goals
because-
and then it's.
Right, because that's,
Both of them in executive.
because that's the part of the board responsible
Yeah,
for.
right.
I think it's got to be.
Okay, so you want those in
Yes.
executive session. Do you want those this month for the next year? Are you ready to discuss the next? As soon as we end this meeting, are we gonna discuss today in executive session, or do you want us to push it to the next executive session?
I think we need to have a discussion now whether we
Yeah.
agree that those
Yeah.
goals are lined out
Yeah.
is
Okay.
up to,
All right.
up to discussion.
So we're moving both of these items, F2 and F3 into the executive session. Okay. So we are now down to rescheduling September and August board meeting, August and September board meeting. I think you had some potential dates.
It's in your packet.
So we wanted to talk about, there was a board member or two that couldn't make our regular scheduled meeting in August. Let's talk August first. And it's, August was, let me get the calendar out so I'm on top. So August would have been the 27th, correct? Yeah.
That's correct.
So if we can, I think we'd like to have all board members here, so we're discussing whether or not we can move the 27th to another day. Anybody have any?
My preference on that would be the Monday, the 25th, if possible.
Monday, the 25th?
I have some existing
Of
commitments on the
August.
26th.
I can't do Monday or Tuesday, so I know both days.
Okay. So we lose one either way. Is there another date we can get a consensus on? I mean, we're gonna talk about changing it.
What's wrong with Thursdays? Does anybody have something?
I'm out on Thursday.
Okay, never mind then.
Well, no, not in August. I could do Thursday in August.
Are we trying to change these going forward because of the
No,
issue?
this
or
is
literally
just for August.
August and September, okay.
Just for 2 months, we have some complications.
Yeah.
So in August, you're talking maybe the 28th, which would be the Thursday.
Let me see if the room's available real quick.
The 28th.
August the 28th, is there anybody that's not available on that day? Cole, you're smiling, so you gotta tell me.
The board is really not available.
Boardroom is not available?
Well, let me look.
The boardroom is always available for the board, I thought.
The Grace River Room. It is on the 28th, actually.
Anybody have any hardship with 2:30, Thursday, the 28th of August? School's not even in. Well,
I think this back in high school for giving that class. I know.
okay, sounds like August will now be the 28th. And Andrew will post that. Going once, going twice?
Someone gonna make a motion?
I have no problem with, what? Okay, well, we're just talking to board. If you can't be there, you'll have to appoint somebody. Would you really rather go 3:30, guys? I mean, I really.
In the school year, 3:30 always works better for me, but as long as the.
Oh, that's right.
I don't want.
August would
Everybody
be.
staying here
Till 10 o'clock,
yeah. So I'll get out of school, just for you. The kids are gonna cry.
I know.
Good kids, move the week here when school starts.
It starts the week before. Yeah.
Teachers are definitely back in. And school and kids are by the 28th, I think.
I understand you could.
3:30, anybody?
No, that's way too close to this.
Does anybody really care whether it's 2:30 or 3:30?
2:30 is fine. I still have to get out of class even at 3:30, so keep
Okay.
it 2:30 and get the meetings done.
All right, sounds like we got 2:30. I don't ever get meetings done on time, I'm sure. August the 28th, 2:30 will be the August meeting. Okay, now let's look at September. The regular meeting was to be the 24th, I think. Is that right, Andrea?
That's right.
Let me get this. And
Any reason we can't do that on Thursday too?
I could do September on Thursday. That's correct. I'm available, so.
So let me.
Anybody else have a problem with?
I'm afraid moving this September date was my issue. Unfortunately, I've got a commitment that's taking me out of town that Wednesday through Friday.
Okay. So what about Monday or Tuesday that week, like the 23rd? Would you be available?
So are you saying, sorry, are we just in the 25th or we've gone beyond that?
We're gonna be on there right now.
Okay.
Yeah.
So the 22nd or 23rd of September. One's a Monday, the other's a Tuesday.
I can't do either of those.
So you
I
can't
have
do either.
commitments on
Ah,
Mondays and
okay,
Tuesdays.
okay, all right, no, that's fine. So if that's the case, then we need to go the week ahead of that or something?
Well, we could go the week after. What about October?
Oh.
Would it be October 2nd? Oh, but then we'd be, okay, then we wouldn't have one in September.
Does that matter?
Does it?
No. We're gonna move it, we can move it to whatever day. So Mondays and Tuesdays are not good for you.
Do the 2nd or the 18th if you prefer Thursday.
Or if it's a Wednesday and you just want to move it back a week on the 1st, that's okay with me too.
Oh, on the 1st, sure.
Yeah.
What about October the 1st, folks? 2:30. We've already settled that discussion at 2:30, 3:30. So I could make October the 1st work pretty easily. Cole?
I think September and October aren't really great for me anytime, so.
This is hunting season.
It is hunting season, yeah.
Oh, well. Okay. October the 1st, instead of September the 24th, October the 1st will be our September meeting, 2:30 here. Okay,
Are you gonna make a motion for that?
do we need a motion for that?
You did it last time.
Okay. Need a motion for both? Can we do both in the same motion?
I'll make a motion that we move the September meeting to October 1st and the August meeting to the, what it is now,
28th.
28th, yeah. 28th.
August 28th. We will appreciate a reminder, Andra.
You have a second?
I'll second. Oh,
Seconded by Abby, moved by Jeff, that we change our meetings in August to August the 28th at 2:30 PM. Grace River Room, and the September meeting moves to Wednesday, October the 1st at 2:30 PM. Any other discussion? All in favor?
Aye.
Any opposed? Okay. The FYI on the hospital trustee symposium that you have in your packet, an agenda, I believe, right?
who's going to?
I will probably go to that. I think if you can, I think board training is important. And so this Tom Mortel, isn't he an attorney we work with?
Yeah.
And I think he's pretty good from what I understand. And he's talking about duties and responsibilities of a hospital board. I would assume we would, I mean, is this over? Leave that morning, and it starts at 9:30?
Yeah, you could probably.
We leave at 7 and be there by 9:30, can't you, hotel, something like that? And then it's closing statements, it's over at 2:30, 3:30. Be home that night, it'll be a kind of a day trip.
Is there a registration fee to attend?
$99.
Yeah, but we'll take care of that.
I'm just, I'm tentative, but I think it's pretty good. You do it, but I've got to change a few things around.
Yeah.
How soon do you need to know if we're in or out, and on that? This is the,
I'm not sure.
August the 15th, it's a Friday, right?
I can explain.
Yeah, you're right.
I don't get it.
Would be Jeff,
I'm planning on it, Andrew, so you can put me down now.
Jeff and Marlo, anyone else?
And then,
And Dan.
And I'm tentative.
I know, I can.
Anyway, I would encourage you to, anytime we have these opportunities close, you don't have to drive clear to Cheyenne or Casper. Hotel is a lot closer. These are always very informative. At least I find them very informative. Similar to our annual one we often go to. These are smaller ones. We belong to this is the Idaho Association, is it we belong to?
yeah, I don't know.
And so a little less expensive also, and we can learn good things about being good board members. So let Andrew know if you can make that Friday. And I assume we might as well try to carpool a little bit. Depending on how many are going, we can
Did we decide when we usually let them away?
tomorrow.
No, I think if I just give them I can give them a placeholder for a couple of spots, and if that is plus or minus, one at the last minute, that's fine. If you need some time to think about it, and just let me know.
You got a golf day or something that day?
Weekend before school.
Oh, is that what it is?
Mhm.
I don't recognize those days anymore. Okay. With that, we need to take another, or is there anything else to discuss? We're gonna take another 5-minute break real quick while they get set up with,
Usually you make a motion to go into executive session and then
Oh,
you
yeah.
take the break and.
well, I was just announcing.
I'll make a motion to go into executive session.
Second.
It's been moved and seconded. We go into executive session to discuss.
Oh, yeah,
You have
where's
your
that
script?
paper? I don't have it.
It's on, it should be on board.
Yeah, it's on.
Oh, it's on board, okay, let
Supposed to
me
be
find
on
it.
board, but
Let's
I've never
see.
found it.
For purposes of personnel matter, real estate and law, legal matters.
It's on board where do I find it?
Where it says
Section
executive session.
It's in there.
I memorized it.
They looked right here before executive.
If you click on executive session section, it'll
Oh.
should pop up.
Executive session. So I make a motion to go into executive session for the purpose of considering the acquisition of real estate, personal matters, and matters concerning litigation to which the hospital district is a party to, or to which the hospital district may be a party.
Motion,
Second.
second by Abby. Any discussion? All in favor?
Aye.
All opposed? We're gonna take 5 minutes so they can get things set up properly with YouTube or something.
Now we know where it's at.
Do we get to keep you in executive session?
No, you're gonna have a free discussion and talk about.
I don't think we need to talk about it.
So do we want our CEO in the first part to discuss last year's goals or any part?
I think it would be pertinent to at least discuss.
We're going forward.
Coming years.
Yeah.
And I don't,
I would
I don't
like
have a
him there
problem
for
with
a few minutes. You don't have to stay the whole time. I'd like him there.
Okay, so why don't we start with the next year's goals, and then we can release Dan while we talk about last year's goals and executive compensation. That sounds good.
Mr. Chair.
Trevor will need you to stay over the whole discussion.
I like talking about people.
Any of us here?
I think what we were gonna do is have executive session with everybody and then discussion of,
But if we don't need it.
do we have to pencil litigation and all the other stuff? I think we do. So I think, you're welcome to leave whenever you want to, but I think we'd like you here the first part, 5 or 10 minutes, just to cover the general subjects, and then when we get into personnel, we'll excuse everybody except certain personnel.
So I was thinking myself, next day, if I knew my wife is a boss.
Yeah, sounds like Dan's got you. We'll cover.
Yeah.
And I don't disagree.
Is the stretch goal?
Well, the spoken talent is a little different than